How do you read my Yeah, because I was in live and I was in instructions, so I thought I needed it. That's all.
No, that needs to be
Is it hard?
yeah.
And you're unmuting me? Hey, good morning, everybody. We are anxious to get started. Some housekeeping items. You see this lovely QR code up here. One thing that you need to know about today is we are trialing quite a few items as far as our ability to provide hybrid events as well as gather information. So being able to be accessible to all members of our membership community, both in person as well as remote. So we have folks, if everybody wants to say hi from inside the room, we won't be able to hear the guys from virtually, but just say hi. Hi, we're here. Have a good group. So one of the things that we're going to use is new to many of you is Menti. So Menti is going to provide us a way to poll and survey and also track attendance. So you can either go online on your computer. So you have the email or the web address there. It's going to ask you for a code. Or those that are in the room or otherwise on your screen, you can scan the QR code and it'll take you to the same thing. These are presenter led. So you will, after you answer the first question, be basically placed on hold until we get to the next poll, which is going to coincide with our different presentations today. At the end of the presentations today, and you get through the polls and surveys, you will have an opportunity to be sent the results. Please know that that is anonymous. You will not see who responded what. That first slide that it's taking you to enter your information, that's for us to be able to collect information to give you information back related to a certificate or CPE type information that you may need. That information will not go to anyone else that's in attendance, as well as that won't track. It won't say, Caroline said this about this particular topic. Nobody's going to see that. So feel free. We want to make this, all of your answers are going to be anonymous to the other presenters and the other participants in the room. So please let us know if you're having any issues virtually. For the folks that are remoting in, please type any questions that you have in the chat. Kalita is here and we always give Kalita great kudos. She's amazing to track all of this. She's asleep well tonight. As well as, I will also want to give thanks to other people who have pulled together this presentation. We have Adrian that's helping here with our technology setup. MHA is always a great venue and a gracious host. My friend Lauren and Sarah from Kohler Consulting that you will hear as well today. We all come together to pull this event together. For those of you that don't know me, I feel like many of you do, but for those that you don't know me, I'm Caroline Zananek, Managing Director with Protiviti Global Consulting. If you're not familiar with Protiviti, our parent company is Robert Half. A lot of folks tend to recognize Robert Half. We're really the consulting arm related to Robert Half, and we're happy to be able to sponsor this event. I'm a Maryland native. I've been involved with Maryland HFMA 20 plus years at this point, and currently have the wonderful role of chair of social media in LinkedIn. So some of the posts and activity that you see is the woman behind the curtain, as well as many of our other leaderships and leadership members. So I am going to ask Sarah to come up. She is our first presenter today. And she is going to start us off with the No Surprises Act. So what we're doing today is starting off with a bit of presentations and then have a panel discussion. So I'll let the presenters introduce themselves. Again, if you have questions, this is more so for the folks that are coming in virtually, type those in the chat. Kalita will help monitor those and likely will get those as time permits. For those in the room, just let us know what questions you may have and we'll hopefully be able to get through all of those. So with that, I'm going to pull up your presentation. So it's all new. All right. Get your presentation ready. Okay. Turn to you.
Thank you, Caroline. Good morning, everybody. So I'm sure that Holly sent our presentations to everybody, and I just want to assure you that I will not be going through all of these slides. I think everybody knows the basics by now. Disclaimer, of course. But yeah, we're really just going to talk about, I'm just going to talk about 2023 requirements, and then we're going to move to our panel. Yes, legislative timeline. It's all there for you if you want to read it. I think the most important thing for us to know right now is that as of January 1, the all-inclusive GFE, good faith estimate, is required. That means that co-provider information is required on the estimate. Okay, scope of patients. If you're not sure whether or not the patient is uninsured or self-pay or considered such by the NSA, if they're work comp, short-term limited duration coverage, liability insurance, health sharing ministries, these are all considered self-pay or uninsured. Now, if a patient has Medicare and they are scheduling a cosmetic procedure, which you know is not covered by Medicare, they do not require a GFE. So government plans such as Medicaid, Medicare, TRICARE, Indian Health, VA Health, they are not covered by the No Surprises Act provisions. They have their own safeguards against balance billing and unexpected medical bills. So you do not need to give them a good faith estimate. Scope of providers. Why it's not showing? Sorry. Everybody. When it comes to a good faith estimate, when in doubt, it applies to you. It pretty much applies to everybody. Dentists, psychologists. Okay. Scope of care. One of the things that's important to point out is that ancillary services are required to be on the good faith estimate. A lot of times they think they're not. Because of the balance billing aspects of the No Surprises Act, there are differences with a good faith estimate. Okay. We went through all this. Uninsured. Oh, one of the questions I get asked quite often, what if the patient doesn't want a good faith estimate? Well, unfortunately, they cannot waive a good faith estimate. You have to give it. Does not need to be signed by the patient, still has to be given to the patient in writing or in a method in which they can save it and print it if they need it for the dispute resolution process. But you have to give it to them, whether they want it or not. Okay. Timing. All right, you'll see that I have 2022 on here. These are my old slides, but this is still applicable. So scenario 1, patient calls on the 7th. They're scheduling an appointment on the 25th. When do you need to get them the good faith estimate? Within 3 business days of scheduling. That's the key. Patient calls on the 21st and schedules for the 25th. You need to get that good faith estimate to them the next day, within 1 business day. Scenario 3, Lauren, when do you need to get this patient their good faith estimate?
You do not have to give them a good faith estimate.
You do not have to give them a good faith estimate. Exactly. It is required for patients scheduling appointments at least 3 days in advance. 2023. Okay. Definition of a convening provider. So this is the provider or facility who receives the initial request for a good faith estimate or is scheduling the primary item, main service. That is the convening provider. Co-providers are any other providers that are furnishing items and services customarily provided in conjunction with the primary or main item or service. Expected charges. This is important. This is the cash pay rate that the provider is going to expect from this uninsured person. So if there is any discount that might apply, it has to be reflected. If you have convening providers that are saying, oh, well, it's going to be anywhere from $200 to $400, that doesn't work. Good faith estimate has to have service codes and applicable charges, not ranges. So the responsibilities of convening and co-providers that they must work together. I think this is kind of where people are running into some difficulty this year. And this is why the departments gave us a little bit of a break in terms of not enforcing the all-inclusive GFE for 2022. But time flies, as you know, and now it's December and everyone's kind of getting a little antsy. All right, let's see. Workflows. We're going to talk more about workflows with our panel discussion, so I'm not going to take time on that. The convening provider. First and foremost, whomever is scheduling appointments at your organization, they need to ask the patient if they have insurance coverage, what kind of insurance coverage they have, and whether or not they plan on using that insurance. That's a requirement. So you have to start right there. You have to provide the oral and written communication regarding the fact that they are eligible or will get a good faith estimate. And obviously, provide a timely good faith estimate. Now, contacting co-providers no later than 1 business day after the request. So after the scheduling, or if a patient is a shopper and is coming and requesting a good faith estimate. So no later than 1 business day, you need to contact any co-provider that is expected to provide services in conjunction with the main item. And it's technically up to the convening provider. They dictate when the co-provider must provide that information, but it's generally within the next business day, because remember, you only have 3. And we're going to go through that with the next, I made a new one. And it gets very confusing. So for scenario 1, that patient that's calling on the 7th to make an appointment for the 25th, okay, you're going to want to contact co-providers on the 28th. You're going to want to require them to give you back their information on the 8th, on the 9th, and then you've got to provide that good faith estimate on the 10th. So scenario 2 is where it gets a little complicated. And this is where you have to have that kind of communication between the providers and the convening providers and the co-providers, because within 1 business day, you have to get all that done. And for scenario 3, the patient that calls on the 24th for an appointment on the 25th. Lauren?
No GFE required.
No GFE required. Now everyone's going to want to schedule everything with him. I don't blame you. Okay, so I stole a couple of workflows from Sean Stack at HFMA. He told us we could. So basically, the convening provider workflow that's recommended is institute an effective strategy to screen and identify uninsured or self-pay individuals. That's your appointment scheduling. Identify common non-covered items and services that may qualify as self-pay. Back again, I say, not for government plans, just so that everyone has that clear. I actually got that information directly from Novitas because it was questionable. But yeah, you can do it by provider. You could do it by health plan. A lot of times that's not easy because there are so many health plans and there's so many different aspects that go into it. But if you know it's a cosmetic procedure and it's never going to be covered, have that ready. Develop scripting for patients. You don't want to scare patients. You don't want them to say, oh, this is so expensive, I'm not going to get this done. This is something that they need to get done. Have the script ready so that you can work with them, have financial assistance, discussions with patients. It's very important that they not defer care because they're afraid of how much it's going to cost. So workflow, convening, and co-provider responsibilities. That's the big one. Include assessing and documenting any patient discounts and charity. Workflow required timeframes to provide the GFE. That's very important, as we saw on the calendar, it can be pretty tight. This is another one. There's a lot of appointments, say an annual exam that is booked 6 months to a year ahead of time. Revalidate those self-pay patients that have been scheduled about 4 days before to make sure their insurance status hasn't changed. If you don't, you are covered because it's what you know when you know, but take that responsibility. Identify storage method and capacity for non-patient GFEs. So you've got shoppers who are trying to find out how much things are going to cost. You still have to keep that good faith estimate for 6 years. So that patient may not have an MRN, but you have to have a place where you keep that. It's very important. Okay, reconciling final charges and estimates. It's another workflow that we definitely recommend so that you're not sending out a good faith estimate or a bill to a patient that's astronomical without talking to them first. So identify your self-pay patients, schedule the service, flag the encounter as self-pay, enter the total amount of the GFE estimate into the patient accounting services. So they have the service, final bill drops, and so have it go into a work queue. If the charges are more than $400 per provider over the estimate, stop the bill, send the account to a review work queue. And also develop consistent guidelines and policies for the staff that are reviewing those variations. This is what you don't want. You don't want a patient to initiate the patient-provider dispute resolution process. This is where they're going to go. They're going to file a claim saying, my bill was more than $400 over what they told me it was going to be. And I'm not going to get into the details of the process. There are some slides about it. If you have any questions about it, just let me know. But I feel like this is something you really just want to avoid. And I think you can avoid it with the workflows and, not letting a bill go out before you've looked at it and made sure. That's all the details. Okay. There are other things. Obviously, balance billing. These are policies that went into effect on January 1st of 2022. So if you don't know about them yet, call me. Yeah, you need to know. Basically, I think everybody knows. Patient comes into the emergency room at an in-network facility. There's no balance billing. So any provider that sees that patient, even if they're non-participating with that patient's insurance, the insurance has to pay in-network. Patient only pays in-network copay and coinsurance, and the providers get to fight with the payers. Yeah. That's no fun. Okay. Oh, non-emergency care. That's always an important one. So no matter what, there's no balance billing for, obviously, emergency medicine. But even when it's a non-emergency, anesthesiology, pathology, radiology, laboratory, and neonatal services, assistant surgeons, hospitalists, intensivists can never balance bill patient in an in-network facility. Now, if a patient goes to an out-of-network facility to receive non-emergent care, guess what? Not a surprise. So none of this, it doesn't apply. They can be balance billed because they know they're going to a non-network facility. Oh, what happened to my slides there? So, same stuff. Notice and consent. Do we want to go into the details? I see a lot of no's. Again, if you have any questions, there's a lot of information on these slides. These are our slides from the beginning of this year end of last year. So there's a lot of details in there. But a lot of it you all know by now. Delivery, see? All these rules. I don't want to take a lot of time from our panel because I think that's going to be the most important and productive portion. So like I said, if you all have any questions, air ambulance services, it's another aspect of the NSA. They can't balance bill. I believe they still have a lawsuit pending. I looked to see if they had settled anything or if there had been any rulings, and I couldn't find anything yet. But needless to say, I think they have a good argument that the insurers have too much power to control reimbursement. But we'll see what happens with that. Another external review, just some little specifics about different things. I put in a bunch of links here. Can get you to a lot of the presentations that have been given over the past year. There's been a lot. And thank you for my portion. So I want to introduce my panel members. I have Jen McDougall, Senior Manager of Patient Administrative Services at the University of Maryland Medical System, and Jay Wagner, Senior Director of Professional Fee Revenue Cycle at University of Maryland Medical System. I thank you very much for being part of our panel. I think it's important at this point for providers to discuss how they're doing things. All right.
Sarah, before we jump in there,
I need to move that.
this is part of that process of us learning what we're doing. I forgot to advance the mentee question for you.
Oh,
Yeah, so
well, there you
some
go.
feedback from some
I'm
of our
gonna go
folks.
sit.
So I got to take you out of this real quick. I will put you right back. So we are on slide 39. All right. So for you guys that on our mentees, so here we go. This is where technology and us is not getting along. Okay. I may have to do it from my computer. Let me know when you guys see the next question. Should advance. Why it's not advancing here. So for those virtually in the room, we should have a question up. Let me know. Do you guys see the one that says, has your organization created workflows to compare estimates to actual charges? Are you seeing that now? See, we knew there was going to be some things. I wonder if it's because I have it up twice. Okay. So, oops, sorry.
No, you're good.
You good? I'm going to bring you back to your presentation while I try to figure this out. So I don't want to hold you guys up. Do we need to move this microphone? Okay.
You guys, but do you have a dedicated individual or team that handles your No Surprises Act, good faith estimates, and notice and consents?
So what we've done at the medical center, the medical system, is we actually do have a central team that we are going to be using for our estimates for the HB side. So we're working on the PB side, and I'll let Jay speak to that. But we actually repurposed another team. I know we're all sort of under that financial crunch right now, so we are not able to go out and recruit and create this great team that could handle all of our estimates. So we've looked at a team that looked at their productivity, saw that they had some bandwidth, and then we just basically added this to their plate. But they are familiar with all of our financial processes. They've done financial counseling. They've done some Medicaid eligibility. So when they do have these self-pay patients on the line, they can see if they qualify for Medicaid. They can offer financial assistance and financial counseling, kind of like a one-stop shop. But that's the team that we've had established. We do have a work queue. We have work queues. But we've got one major work queue for the hospitals where all of our self-pay estimates populate. And that team is going in and looking at those estimates and just kind of giving them that second look. Surgical estimates are a little bit different because the surgical self-pay is a little more complex, and we tend to put a lot more eyes on it because surgical self-pays aren't, super popular. So we tend to make sure that those estimates are super tight and really accurate as we can get it.
Yeah. So from the professional side, I think this is actually what was really good about Jen and I both being on the panel is you have kind of this HB focus and this PB focus and where the interplay happens. It's a little bit different on the PB side because those folks at the practices are truly the operational owners of the scheduling. So instead of having a centralized team for PB, we really rely on those practices to run point on that estimate creation for those patients. We've done a lot of work with all those practice managers. We started early in the summer with a practice managers forum that brought everybody together with whom we work and just started listing out, starting with the overview, but then all the details of what needs to happen and then say, hey, what's unique about your practice that we don't know about? Because every practice, be it the Shore or somewhere at Upper Chesapeake, may have just a slightly different nuance that we have to account for. And it may be a process issue that we have to address because of what is required from an NSA perspective. One of the things, because of that being localized at the practice level, to Jen's point about talking about work queues, we developed specific work queues for each of those practices, but also came to an agreement on universal language that would be done. So department, no surprises, NSA review. So it's very, very simple and easy for everyone to know. So if you have somebody that jumps from one practice to another practice because of a promotion opportunity, whatever, they don't have to figure, well, how did we name it here versus how do we name it here? It's simple and it's consistent. And then folks are obviously within Epic able to favorite that work queue. The challenge that we're having thinking about from the convening provider perspective from a PB standpoint is those non-affiliated ancillary services or anesthesia services. We have a lot of that's outsourced from our practices today. So where we have to go right now is through the portals, and Erdney actually helped provide some of the insight that we were looking for on some of that. So using one anesthesia group in particular, they have a portal where you can pull down the information and see what the charge would be once their portal is live. From a radiology standpoint, they have theirs live and ready to go, and you can see the detail. But the challenge that we're wrestling with right now is if we're pulling that to create our convening provider GFE, do we then take the ownership of the accuracy of that charge? Because they're giving it to us through a portal, but not necessarily a contact or a conversation. So what really happens there? Where we're landing or where we're going to start talking about with our legal department is there's disclaimer language on that advanced radiology site, for example, that talks about their accuracy components or whatever. Do we have to incorporate additional language into our GFE to say these non-affiliated ancillary services are accurate based on the accuracy of that group's portal? That's something that's still to be determined, but was a very good aha moment for us. Because these outside groups, they're not going to have a call center of people you can just phone a friend and talk to and say, hey, what is this? They're just going to make it as simple for them as possible. Portal is their way to go. So how do we ensure that we're not taking on more onus or responsibility than we have to?
We skipped to the.
Yeah. Jay just skipped all the way to the third page.
That's okay.
I'm teasing.
That's okay. Hey,
That is what we call
whatever's
efficiency.
important.
He's all off script.
These are
We're
the
all
things
thrown
that
off.
are on your mind. That's what's important. Does anybody have any questions on that?
I did have a question for the have any overlapping where you have any external practices that are also hospital-based?
So I'm going to repeat the question just in case anybody cannot hear it. So is there any overlap between the hospital-based and the provider-based? I didn't remember the whole question.
Yeah.
So short answer is yes.
Yes.
We have several working groups that are some HB focused, some PB focused, but a lot where we're overlapping. And we have to do that with community provider requirements. Anything where you have those place of service 22s, our piece, Jen's piece, that comes into place. We have to ensure we know what each side is doing. And there's been a lot of really good discovery that has come out of that. And say, wow, hadn't thought about that. Good point. We need to go back to our technical teams to figure out how do we build that out appropriately.
I think what Jay said, when there's an aha moment, I feel every day there's an aha moment with NSA, and we're just like, oh, okay, well, let's take that down. That's going to have to go to legal, or that's going to have to go, here. We're constantly learning something new about this legislation. It can be extremely frustrating, and you just really want to go back to whoever wrote this legislation and be like, why?
What
But
were you thinking?
but ultimately, I have to. What I always do to kind of ground myself, because I end up getting a lot of the patient complaints as well, is that this was written with a patient in mind. You know what I mean? And that's what I just have to keep bringing myself back to be grounded on. If I was a self-pay patient, I'm fortunate enough to have insurance. If I didn't have insurance, I would want as much transparency as possible so that I can choose the right care and have, know what my financial options are, know what my, bottom line cost is going to be. So I have to just kind of bring myself back to that. But there's a ton of aha moments in this legislation for sure.
How often do your groups meet?
More times than we can count.
I mean, Ernie's on my Christmas list now. We meet every single day. I mean, and sometimes multiple times per day.
You have a question?
Yes, I was wondering if others in the room did, Jen, what you started with, where you had to repurpose. I was just curious if others in the room were kind of nodding their head at that too. Is that kind of what everyone's been having to do with this?
With staffing? Laura was asking about staffing, repurposing, and if anybody else in their organizations had to do the same thing.
Are there no?
Jen's nodding her head, but she's up. Yeah, Christine. She agrees.
And it was also sort of level setting the role of the scheduler, because some schedulers are just like schedule. And now we're like, well, we need you to ask for insurance. Whoa, that's not part of my typical workflow. And I actually got a call on my way home last night from a scheduler that, she met her productivity standards that we have set, but we set a stretch goal. And then we, in certain circumstances may provide an incentive if the team reaches the stretch goal. And the team as a whole did not reach the stretch goal, but she reached her stretch goal, but then wasn't eligible for the incentive because the team didn't reach the goal. And so she was hot and bothered about this. So she called me on her way. I was on my way home. She called me and she's like, well, I just want to let you know that now that I have to, basically ask the patient if they're using their insurance and then add the insurance to the account, how much more time it adds to each encounter that I'm scheduling. So we might need to revisit these productivity standards. Fair enough, but it was something that, I said, okay, thank you for calling me. Thank you for bringing this to my attention. I understand, but it's something that organization-wide, these schedulers are just kind of like, that is not my workflow. So we've really had to re-educate, and there is no choice. That it is a, it's a legislation. It is a must. You have to do this now.
Just a quick question. From an analytics perspective, what sort of tools do you anticipate using to provide some of these good faith estimate numbers? Or is it more of a manual process based on the historical trends?
So the question is the process manual, or are there analytic tools that you're using? I think you all have Epic.
So on the professional side, what we did is we looked by each practice and then got a historical trend of the CPTs that were utilized by clinic and by provider. So if we know Dr. Smith typically does level 3s, but Dr. Jones does level 4s, when Dr. Jones's GFE is generated, it's going to generate with that level 4 versus the other provider who typically does the level 3s. Where that gets a little nuanced, and that goes back to what we were talking about with some of that $400 threshold, is if the provider says, hey, day of service, I need to do a lumbar puncture on you as well. That wasn't in the GFE because that was decided at the time that the patient presented. And the patient could get a charge. It's like, wow, this wasn't in my GFE. And they might go through the dispute process, which would make sense based on those lines. The key part that we've also indicated to the practices and to the providers is good clinical documentation is going to win the day. If we have those inquiries, it's fair to ask, but the resolution likely will be very straightforward as long as the documentation supports, hey, I had to do this procedure that was not known at the time of scheduling, and it will give us a way forward through a successful dispute.
And we could also rerun a GFE at the time, with the patient right there also to, just for more transparency. On the HB side, we use the Epic Estimator tool, which is a historical 6-month look back. And we have built templates. So if I'm, scheduling a follow-up visit in the diabetes clinic, it'll auto-populate a template and then we can finalize the GFE. On the HB side, we definitely had a leg up because we were already doing estimates for FFD. So we kind of felt like, okay, estimate, we're good to go. But, we're not really realizing on the PB side how sort of nuanced that is. And then, of course, combined templates, that's sort of where we're headed next.
I completely forgot. That's a really great point, Jen. I use this description of a marathon. Our HB partners had like a 13-mile head start on a marathon, where PB, we just got out the gate. So it's been a lot of work for all of our professional practices to kind of catch up. I think we've done a stellar job getting ourselves there, but it is not without a lot of strife and aha moments and everything else because we didn't have that facility fee disclosure requirement on a PB side.
That's a follow-up question, Jen, and Jen too, is when you have a situation where the actual charges are in excess of your estimate, are you flagging those internally to proactively talk to the patient, or are you waiting to see if they go into dispute resolution?
So the question for folks who may not be able to hear, if we generate the estimate and it ends up being in excess of charges, how are we doing that from a review standpoint? I got that correct. So we do have a process where we can examine that pre-bill and cover down. That's still something that we have to test a little bit further because, again, that's something we didn't quite have fleshed out in the PB standpoint. When we were looking at building our workflows, we had to start the most basic components, but that is something we're working to finalize.
Have you had any patients initiate the dispute resolution process?
No.
Yeah, I know.
Has anybody? Anybody's organizations, providers?
One client, but it was a frivolous request, but CMS was still making them respond.
They have. I mean,
They did nothing wrong with the right.
right.
And people on the chat could chime in with these questions too. That were
Absolutely,
thrown out to the group.
please.
So we said that tonight.
Yes, if you have any wins or any questions, please type it into the chat so that we can address questions. But also, if you've got anything, any information that you can provide that can help, or like I said, any wins.
And let them know too that the mentee is corrected.
Oh,
So if they
mentee
want
is
to go
corrected.
Through the poll, I can start giving you results on the poll.
Okay.
that we put together.
So if everybody wants to check the Menti again, you can answer the polling question, and we should be able to get
The
some.
mentee responses so far.
Woo!
Please go ahead.
Yeah, so a lot of the onus, right, we're in revenue cycle, it's all down on a lot of the back end operations, the business, and then the boots on the ground team members who are actually doing the communication with the patients, families, about these services. Since this is kind of new for everyone, what other, I would say, analysis you would be doing? So like, as you see maybe disputes arise, is there any kind of AI to say, is it tied to a particular provider? How are you closing the gap to say, well, maybe this particular provider schedules for just one visit, but we see a history of once the patient comes in, there's an explosion of different things that continue to go outside. So how are you gonna kind of bridge the gap of communication with the providers and the services that they are coding, and providing, back to your team members to make sure that, there's full level of transparency. It's starting at the end, but at some point, we'll need to connect with decisions that providers are making or the communication, right, that is being delivered to the patient. So just, have you thought about that, or are you engaged in any work with looking at how providers are coding or how they're communicating with the patients?
So I'm going to do my best to summarize the question, but it was asking for thoughts on, what happens after a dispute resolution is initiated. What is the communication back? Because there's a back-end component that will see this, and how does that information then get to the front end, and what sort of analytics or AI are we looking at? Did I do a good job summarizing?
Yeah.
Do you want to start, or do you want me to kick off?
You can kick it off.
Okay.
Because I can finish it.
Okay. So the analytics is something that's in flight for, at least for us right now, that we're looking at, of what does our compliance look like once we're live. So we don't know what we don't know until things really start coming down. I think that'll give us some insights into the trending based on the reports that we are developing for that compliance component. And then that'll give us the ability to kind of go back and say, okay, this clinic or this provider is having particular issues. One of the things that obviously comes in is just our regular day-to-day mid-cycle is if we're seeing certain documentation issues, we just give that real-time feedback to the provider via either in-basket, in Epic, or any other provider education processes that we do, or the prospective audits that we may do within an MD audit. So those things kind of help right now, and will likely be a part of the strategy once we have some actual data with those compliance reports that we'd be looking to develop once we start implementing the workflows. Okay.
And for any of our estimates, because we do want to look at our estimate accuracy, we work with our Epic TS, and they actually run reports for us, and we can see, okay, this is what was estimated, this is what was actually billed, and we can go back and look and see, okay, we're way out of whack in this department. We need to go back and revisit, how these templates are being mapped, or, okay, a lot of these were manually manipulated and why, so we can go back and just kind of group them, look at where we have some targeted issues, and then, this process is a continuous merry-go-round, right? We have to keep re-education, reviewing all of your metrics, reviewing your reports, and then re-educate again, and then go back and just revisit, re-educate, just over and over again.
So I have a question, because we talked about this a little bit. You spoke about how, the reason that this legislation came about was to protect patients from just astronomical bills that they don't expect. What kind of feedback have you gotten from patients?
So it's difficult, especially with NSA now, because everyone was already receiving in hospital regulated clinics, the facility fee disclosure, and that it requires a verbal, okay, we're providing you this estimate. These are your, we read them the disclosures, we tell them what the estimated charges are for their visit, and then they actually have to sign a document when they come in for their appointment to, that they acknowledge they've received the disclosures. With NSA, they're also receiving a letter. They are two separate and distinct legislations, so they get two separate and distinct notifications. Patients hate it. They absolutely hate it. I'm a number, I'm not a patient, I'm just a money for your organization. That's all you want from me. And it's very difficult to explain to a patient when they're angry about being told about what they will be charged, that it's for their protection. They just don't hear it. You know what I mean? Because how is this protecting me? I guess I'm just not going to get my care. I can't afford this. So it's very tough when you hear patients coming to you and saying that they're just a number.
And you can't waive. They can't waive it.
And they can't. And if they stop calling me,
say,
especially for a facility fee, we have to call them. If they weren't provided it at the time of scheduling, we need to call them and provide them with their disclosure, and then mail them or populate it in their MyChart account, the actual letter. And they stop calling me. We can't. It's a requirement by law. And it's very tough on the folks who have to make these phone calls. I see it's a huge patient dissatisfier. We say that loud and proud in almost every meeting we have with legal.
Does anybody else have any experiences? Patient dissatisfaction? Anybody online? Type into the chat. I found that interesting because I hadn't thought about that, but it makes sense. I mean,
So now I guess from the employee standpoint, how are you helping to support them knowing that, I've had that job before, well, it's been a long time ago, I can imagine having those conversations, that's tough.
It is, and the toughest part is that these folks are required to know these legislations and to know these regulatory requirements, and we have a ton of turnover, in some of these positions. And, we're trying to retain these folks, but it's a very competitive market right now. And if I can jump ship and go over here and make, $1 more an hour, I'm doing it. You know what I mean?
Please
So-
don't.
You don't want me to come work for you, Jay? No. But, it's things like that we're struggling with, it's, okay, here's something else you need to do. And just, even the employees, it's a lot for them to take. And we try and do as much as we can to offer support. And I've got a difficult, or I've got a really high estimate and I'm uncomfortable making this phone call. I'll make the phone call. I want them to know that they don't have to, if they're uncomfortable because it's a higher estimate, I'll go in, take a look at the estimate, make sure it's accurate. I'll make the phone call.
So are you increasing your customer service training and strategies around that? Are you seeing that need?
Yes.
Yes.
The short answer is yes, we are seeing that need. We are seeing a great need for education in our customer service area also. Our patient access team bears the brunt of any of the customer service requests because they sometimes they can only do with, whatever their bandwidth is and whatever their knowledge is, and then they escalate things to a higher authority. I actually just had a conversation with this, on this yesterday, that I do believe we're going to need some really strict governance around this, a committee of people who, and I, we're going to have to, volunteer people to be on this committee, but we're going to need people to be on this committee that can really help, you can escalate this, right now customer service is struggling. Like, what practice manager do I reach out to? Who do I need to go to over here? And then if they don't get back to them right away, and then this complaint just ages, we have to have some kind of, overarching authority where, okay, I've reached out to the practice once. I haven't heard a response. It goes to the governing authority and then they step in, or maybe the authority steps in right away. I don't know.
And Caroline, to your point about additional strategies we're thinking about from a customer service perspective, in today's world, we're not an SBO, but that's part of our journey at UMS. One of the things that happens with SBO is obviously that integration, but right now we're thinking, does integration with customer service make sense before SBO just because of that interplay between both sides? We have our separate HB and PB customer service teams today, but there's going to be a lot more partnership that's going to happen. So there's some very early discussions of what do we do strategically around that's in line with where we want to go in the future, but we may want to implement that strategy sooner because operationally we may have to.
anybody else have any questions? Absolutely.
I think what's good, at least for my clients, one of the questions that we typically get asked, I'd be interested in you is it who owns the process? Because I hear it from, we get questions from internal audit, we get questions from compliance, is it revenue cycle, is it his, like, how do you pull all that together, really align your accountability and expectations from the whole workflow related to, even just the estimate? And
for those who may not have heard, the question was related to accountability and aligning all the different components of the workflow. Can we start again?
It's up to you. Yeah.
I can talk too.
Yeah,
I'm
no,
verbose.
go ahead. No.
It's a challenge because there's so many entry points that there's a lot of people that kind of have a shared responsibility on all this. It's not necessarily one single source of truth. And even going back to how we started earlier in the conversation of HB has a centralized process. We have things at the practice level. On the PB standpoint, there's different direction points that happen from that responsibility. So I think it's really taking a deeper dive in the inventory and understanding, who's responsible, who's accountable, and then what is the escalation process that may need to happen, to some of what Jen was talking about earlier.
I do think that UMS would look at it as it lives in revenue cycle. And then they would just collaborate with all the other, arms and legs of the organization.
So Sarah, on your poll, we have 34 answers. So if I want to, I can pull it up so
Yeah.
everybody can see it on the screen. But the majority are saying, yes, they have the workflows to compare, but they're struggling.
Yeah.
Right, so.
So Caroline was saying, we're going to look at the poll responses, but the majority are struggling. Oh, wow. Yeah.
That's where we're at.
Not surprised. I mean, the 10 is fantastic.
Absolutely.
Yeah.
The 10 is, it's not to say that they're probably not having issues that keep coming back, but I was going to read it. So the question was, how has your organization created workflows to compare estimates to actual charges? So yes, we have a fully implemented process in place. Yes, we have workflows, but we're struggling to perfect the process. And no, it's just a struggle to get the estimate generated and distributed. And it
I
jumped.
think it's staying within the bell curve.
Yeah, definitely the bell curve. I was going to put no. What's a good faith estimate? What's a workflow?
I don't have a microphone, but that they can hear it. We still have, more so not the hospitals, but more so the provider organizations that we see. And it surprises me, even some of the nationally large ones we talk to, still don't quite even understand what the no surprises sound.
Actually,
That's concerning.
I agree. Well,
I agree.
I think there have been
Yep.
at least questions that we've gotten over the past year that many providers didn't think it applied to them. They thought it was only hospitals. It only applied to big organizations, things like that. I mean, I went to my own physical therapist and I was like, I said, oh yeah, so I'm doing a talk on the No Surprises Act. She's like, what's that? And I'm like, oh, we have to talk. Because it does apply to all providers.
We struggle with that with education because we have a lot of, ambulatory services. And when I was, I got a call from a practice down at our Shore location, and they're like, yeah, I'm being told I need to go to this training. But then, my informaticist said I didn't need to go because I'm unregulated. And I'm like, no, you need to go. And they're like, okay. So then I get a call from the informaticist. Well, they're moving to VFO. So they're hard now, but they're going to move to VFO. So no worries. I'm like, no, it's for everyone. And I had to re-educate that. And we're going back and back and back. I'm like, it doesn't matter where you work. You need to provide a GFE, regulated, unregulated, anything. You need that GFE. And I feel like FFD sort of hurt us there because everyone just FFD, that's regulated. So, okay, don't worry about it. Oh, well, I'm unregulated. I don't have to do that. That's the same thing as FFD. No, it's not. So it definitely is back to that education.
I think they would confuse it with pricing transparency.
Absolutely. Absolutely.
I was going to say, yeah, pricing transparency, right?
I think though that was the one thing that we also did pretty successfully at UMS was we really reinforced what is required at every opportunity that we could. We didn't just presume that everybody knew what NSA was required. And through that, it just even in meetings where it may not have been the primary topic, it came up, said, yep, this is going to be applicable. Here's where it is. That would generate additional conversation. So I think that was one strategy where we were pretty good. Even though there was still some confusion, we were able to right the ship pretty quickly because we planned to be that agile.
So Jay, going on that, we wanted to repeat it for him. Are you doing any outreach for your community providers that are not affiliated, they're not UMS providers, but maybe community providers that have privileges at even like the Shore Hospital?
Yep.
Yes. Yep.
So the question was, outreach or strategies for non-affiliated providers who may come and provide services to our organization. So we have had that outreach Some want to play ball, some don't. That's yeah, and that's another challenge. Is it may come to a lack of knowledge, as Sarah's referring to, or just not a willingness to engage. And we do the best that we can.
I have a question for you, Jen.
Yeah.
And it's kind of getting us back to the question of repurposing of staff. So there's an explosion of self-scheduling, right? Going to portal and scheduling. And it ties the dot between, are you seeing an opportunity? How are you handling those? Are you repurposing maybe the sense that you don't maybe need as many schedulers on the line, but they are repurposed to call back? How are you handling this explosion of self-scheduling?
So to repeat the question, how do we handle the explosion or the increased utilization of self-scheduling?
So we're phasing in our self-scheduling right now. And I'll tell you what, I take advantage of it. I love it.
I love
Less
it.
people I have to talk to, better. But it's definitely, it's a challenge when it comes to this legislation because, we had to build into our self-schedule questionnaire, if they're planning on using insurance. And then we also give them the opportunity to choose what insurance that is also. But we brought up some concerns, because if we're, pre-regging or if we're, doing anything with these folks and they're scheduled 6 months out and they're self-pay, we need a way to find those people who are self-pay that are self-scheduling, because otherwise we're not following up with them until 14 days prior to their appointment to pre-reg them. So we have to, then, okay, let's think another step down the line. How are we going to collect all those folks, plop them into a work queue? So since if they do choose that they are self-pay, they will fall into a work queue and we can capture them then. But what if they just don't choose any insurance? You know what I mean? So we have to be very vigilant working with and it's something that like maybe our MyChart folks didn't really think about. And now we're hammering them with this and it's adding a little wrinkle into that whole self-scheduling process. But yeah, it definitely requires a lot more follow-up. We haven't seen the benefits of X number of people are now self-scheduling, so we can repurpose X number of schedulers. We're not there yet. We're slowly phasing it out, phasing it in. We have definitely had a lot of providers that are like, I don't want to do that. And they really don't have a choice. They're moving forward with it. We have a very formulaic approach for how we're phasing that out. I keep saying phasing out because I mean roll out, but it's phasing in.
Well, we're at time.
That went really fast.
Well, there's a lot to talk about.
Yeah.
We knew that. That's why I kind of buzzed through the slides. But thank you very much.
Oh, no, thanks
Jay
for having
and
us.
Jen. Really appreciate you being willing to share your experiences. And like I said, if anybody has any questions, wants to type it in, we will address all the questions. And thank you all for participating.
Great job.
Thank you.
You're gonna sit here, right? Are you sitting here? Next. Okay. All right, guys, we're going to take a little bit of a break and come back. I believe I don't have my 10 at 10:15. Thank you, Kalita. Keep us straight. Which revenue cycle topic is causing you the most concern recently? If you look at these and say it's all of them, there is an option for all of the above, which right now is in the lead. So our options are preparation for January 2023 coding and modifier updates, which Lauren and her team presented a beautiful presentation a couple weeks ago, last week. Wow. Time warps. Okay. Resolution of payer requests and or denials. I think everybody will say yes to that, but it's probably falling into all of the above. Category, what we just talked about, the No Surprises Act and the facility fee disclosure requirements, or FFDs for Maryland hospitals. All of the above. None of the above. I would love to know who has none of these concerns. Anybody in the room, or are they online? Or is it because you're a consultant? And you really, okay. The not sure, that could be kind of the same thing too. So I know as being a consultant, sometimes it's like, well, I could answer this for the majority of my clients, for myself, so I kind of default to the not sure, none of the above piece of it. So we'll continue to gather this information if you haven't had a chance to go ahead and poll. I don't want to take time away from Lauren's discussion. So I'm going to pull up her presentation. We'll go from that. And just a reminder, when you get done with the mentee, there is an option to get a copy of those results. So if you're curious, take that back to your organizations. You'll be able to do that as more people answer. It should be updated. So if you want to wait a day or two as people are updating, you'll receive an email. We tested this last night. You'll get those results. So it's not just that point in time as people are continuing to answer. That'll be active and update for you. All right, so I'm going to turn it over to Lauren.
Sarah. All right. Wow. Okay. Oh, thank you so much, everyone, for joining, whether you're virtual or in the room. Really appreciate it. And Caroline, you have been doing a wonderful job emceeing the event. And Sarah, Jen, and Jay, great presentation. Really enjoyed that. So we are going to kick off our presentation. I want to introduce the panelists that are to the left of me. Jen Gardner. For those that don't know Jen, she is the Senior Director of Revenue Integrity for University of Maryland Medical System. And Christine Thomas is in the middle, and she didn't get the wear red memo, but we let her sit with us anyway. Christine is the CDM Director for Revenue Management and Reimbursement of MedStar Health. So the three of us have known each other for decades. Not sure if that's good or bad for all of you, but we're thrilled to be with you today. Sarah, can you move to the objectives? Oh, you're one step ahead of me. Okay. All right. So we are going to touch base on, always Sarah, one step ahead of me. And for those that don't know me, so I am a vice president for Kohler Healthcare Consulting. And so I do work with Sarah, who moderated our last panel. We're going to touch on the updates from last week. If you didn't catch last week, that was recorded and a lot of great information shared. We're also going to talk a little bit about the HSCRC and relative value units. And then I'm hoping for the majority of the time, we're going to talk about what's going on and, what is top of mind. And we're hoping this doesn't turn into like a group therapy session, but if it does, it's fine. So, all right. Okay, perfect. All right, our topical slide is on the screen. Thank you, Sarah. Okay, so I'm going to kick it off with, we decided yesterday that we would start with a very positive note, and we are going to do that. This year for facility chargemasters, it's really not bad. There's maybe we should be knocking on the table because sometimes when you dig into the details, but it's not as bad as other years have been. Pro fees, different story. With the E&M updates and like surgery and, codes that need to be applied by coders, tons of updates there. But for facility chargemasters, it does not look too bad. The curveballs that we found so far, and Christine, I would love for you to share it, is with a pharmacy HCPCS situation. And we'll talk about modifiers, so we'll stay on pharmacy for a little bit, but
So just the J.
yes.
So one of the things that has recently popped up at our facility is the J9049, which I can never say the names of the drugs, but it's the bortezomib. Yeah.
That particular drug.
So, in the past, you had the J9041, which was the brand, the Velicade, I think it was. And then you had the J9044, which was used for the generic versions. So this year, when the HCPCS came out, we noticed that they were inactivating the J9044 for the generic, but the replacements that they were giving were very specific, the three, to particular manufacturers. And the one particular manufacturer that we get our generic from was not on there. So we are kind of at a loss as to what exactly we're supposed to use now. Because again, it's inappropriate to use the brand if it's generic, but yet the new generics aren't necessarily slotted for what we use. So we are kind of, do we go back to an unlisted, which then, again, causes problems because we had already been having issues with our oncology and infusion areas because they have to get pre-authorizations of these drugs. And then they're getting a pre-authorization of an unlisted, which is going to cause, so it's just causing all kinds of headaches already. So just wasn't sure if anyone else was seeing this or having issues or suggestions.
They might be like next week. Let them enjoy the weekend, Christine. But no,
What's the medication used for?
I am not.
I know it's used in our infusion oncology clinics.
Yeah, it's a J9 code, so it's a chemotherapy drug. So
You're asking me to get clinical.
if the code starts with J9 and the drug name ends with MIB, it's usually chemo. So anyway, pharmacy always has a lot of updates. So just an area, pay attention to that, especially when you're updating your systems and making sure that the pharmacy system and the back end are in sync.
Because wasn't there another one where the units were changing that we just needed to make sure?
Yes. So, this one's even harder to pronounce. I'm going to give it a go though. Chloropropane it's not as bad. Hydrochloride. So, this particular drug, they inactivated, and this is J2400. They inactivated, and then they added a J2401, and they completely changed the units. Now, maybe that's okay. Sometimes they make a change like this and it looks major, but really they're just moving it in line with how the drug is issued. So anyway, pharmacy, probably the area that's going to be causing the most amount of work for facilities this year. And I guess that there's no better time than to talk about the waste modifiers. Jen, you look thrilled about the new pharmacy waste modifiers.
I do. And, we're an Epic facility, so I don't how many other ones, but pharmacy is a little bit of a carve out in Epic. So it's not really owned by Revenue Integrity. It's really owned by our Willow team with some oversight by us. So we've kind of started that process. They said they're aware of all the changes. So we always do then a kind of a follow-up to make sure they're following through with the changes. So I had inquired last night after we had talked, and they're like, we're working on it. So I imagine next week I will hear that some of these issues, those issues are going to come up. When I was following up with them with this JW modifier, again, I'm not sure how many folks are already using that in Maryland. It had previously not really applied to us in Maryland. Some hospitals, I think, have chosen to use it. Others have not.
Jen, will you explain what JW means for anyone in the room that?
Yeah. So the JW, for those that don't know, is for the waste, and it's related to the single dose vials specifically. So that's what we're talking about, are those single dose vials. It gives hospitals the opportunity to bill for the waste. So it's interesting. We've had a couple facilities that have wanted to turn it on for certain drugs. And I'm like, oh, we're not gonna handpick which ones we bill waste for. I'm like, that sounds like a compliance no-no. So, and compliance did support that decision. So, so again, for us, I have my Willow team investigating this, and they're, for us, again, on Epic, they are working with Epic to see how we're going to resolve this. What I had just heard was there is a way that they can do this in Epic. Currently, they are running a search in our formulary to see which drugs this applies to. So once we identify all of the medication records that are eligible for the JW modifier, what I have been told, it should be relatively easy for us. Now, I always hate when they say that because that's usually not the case. But for us as our Epic hospitals, we have shell records for our pharmacy drugs. So all of this really resides in the formulary on the Willow end. So kind of for me, drugs, I'm like, okay, it'll eventually work out. For those hospitals that are 340B, this is where, and I know just enough about 340B to be really, really dangerous. But the JW modifier, what I've been told from our 340B experts is, even though the JW modifier did not apply in Maryland from a billing perspective, we still had to calculate all of that waste from a 340B perspective and do reporting on it. And I heard it was a very manual process without having the ability to use the modifiers. And I'm looking, anybody has information to disagree with that, please let me know, because my information is one-sided.
Yeah,
So
I do agree with that, because that is why our facilities are looking to implement the JW in our Maryland. We implemented it in our DC hospitals, but we hadn't done it in Maryland. And one of the reasons they want to is for the 340B purpose.
And what I've heard is it's very, without using it, it's a very manual process. It's very resource intensive. Now, for whatever reason, and we're still exploring that, our leaders did not want to, or let me just say our pharmacy leaders, let me put it back to them, still do not want to bill for the waste. And I think it was a little bit more that they wanted to make sure there was no case of us doing anything fraudulent, that we are billing charges that we shouldn't be charging. So we're still exploring that, because I think we had queried Novitas, Lauren, if
I think individuals are in the process of doing that.
So we had done that previously, which is where we had gotten the statement that we didn't need to use the JW modifier for billing waste previously.
A few years ago.
So I think that's what we're hoping to be able to do. But so we use Macro Helix, and I don't know if that's what everybody uses, or we have a vendor that helps us with our 340B process. And what I'm hearing is it's not what the solution for Epic and how we're going to handle it isn't working quite as well as they hoped on the Macro Helix side, which I guess is usually what's happening.
I thought you said it was going to be easy.
Correct. But this is next week's problem, Lauren. So, this is definitely a case of no news is not always good news. So when you ask the additional follow-up questions, it's not going as easy. But needless to say, this goes into effect July 1st. There is another modifier, which is the JZ, not the musician.
Right, not to be confused with that.
Which will go into effect July 1st. So you have a 6-month reprieve. And my understanding of that modifier, that is your attestation that you're only billing for.
That there was no waste.
No waste. So you have a 6-month reprieve once you figure out the JW to make sure that you get the JZ in correct. Anybody started this process, exploring the process?
I have a question / concern.
Okay.
Is Epic the one telling you if they're applying the JW modifiers, which ones they should apply it to? Or is that your Willow team?
That is our Willow team in conjunction with our Epic TS. I'm with you.
Caroline has trust issues.
I have major trust issues. No offense, but it's usually related to consultants.
No offense.
So yes, 100% it is our team, but we use, again, from a resource perspective, I think they use a lot of the Epic TSs to do some of this work because everybody's short-staffed.
Sounds historically compliance experts.
100% agree.
Yes.
And especially then when you throw in the Maryland nuance, it throws them all.
So let's, for a couple minutes, let's talk about this Maryland nuance, especially if we have anyone joining virtually or in the room that were not born and raised in Maryland, like us, I believe. So with the Health Services Cost Review Commission, the HSCRC, all hospitals in Maryland are already under global budgets. So that means it's not, whereas like this whole waste situation is real dollars outside of Maryland that CMS could save or expend additional dollars, in Maryland we're already capped anyway. So when this came up, as Jen mentioned a few years ago, it was actually CMS that responded. We reached out because everyone was like, do we have to use the JW? Do we not? We reached out to CMS and they said it really doesn't apply in Maryland because your revenue is already, being controlled. However, after that, I know some organizations would go through a Novitas audit and they would ding them for not using it. And I think ultimately it would get resolved, but it's always just been a kind of gray area. And they never, outside of an email that I have, framed on my wall, we don't have anything in writing. Like if you went to cms.gov, you would not see Maryland's excluded from this. And then the final rule this year, when they introduced JZ, you don't see that Maryland's excluded. So it is a little bit gray. I think there is maybe still a chance that Maryland hospitals could be exempt for the argument that worked a few years ago. Our pharmacy person read those pages of the final rule, which if you've ever read governmental pharmacy language, it's fun. It's real fun. It's like, what are they saying? And what it appears they're trying to do is use these modifiers for informational purposes so that then they could go back to a drug manufacturer and say, why is your vial size 150 milligrams when the average person, it would only be 100. So every time this vial is used, 50 milligrams are wasted. Why is that? They would have that data. But, if you look long term, I don't know what that's going to do, really. You would have data. Is it really going to save CMS money in the long run? I'll believe it when I see it.
Because the manufacturer is going to reduce their size and raise their price.
Correct. So, so pharmacy math doesn't usually work that way. It doesn't usually go negative. But we'll see. So because it's informational, the point I was trying to make is if it's informational, then they probably would want data from Maryland hospitals. If the concern right now is not revenue so much as that. But anyway, that's a situation that you want to keep your eye on. As Jen mentioned, I would let the pharmacy experts do most of the work. But as Caroline reminded, kind of be there to make sure it's compliant. It's, there's not going to be any backlash from decisions that are being made. Anything else on
And
pharmacy?
actually, what you just said there is so key with Chargemaster revenue integrity is always doing the sniff test. That's what I kind of call from anything the application teams or your IT teams are putting into place. Because, and gosh, I stand on my soapbox all the time with, you have to include revenue integrity. You have to include, please include us in the beginning, because we have always brought into projects after the fact. And the train has already gone down the path, and then we throw in all of these wrenches, and we always, and that's what revenue integrity's job is. We are the police, we are the bad, the no sayers, but that's our job. That's to protect the organization, but it gets us a reputation of not being.
If you work at OMS and Jen calls you, it's not good news. It's never.
But it's just, so I think, so that point, the sniff test, but that's with anything. Just make sure whatever is being put into place follows your compliance, that you think it's following the Maryland regs or CMS regs, because often what Epic or your, various IT folks, they think they're doing the right thing, and they have the best intentions, but there's usually like, oh, you missed that. So
Because the regulations are often hard to read. the three of us could read the same sentence written by the government and take away three different opinions, and we'll fight it out. We'll ultimately agree, but. All right, so before we change gears and start talking about the HSCRC a little bit, the other updates for this year, there are a lot of new technology codes. So if departments at your organization are all excited about these codes, just make sure that they're covered. And then just like any new CPT code, you do have to set up an HSCRC RVU, relative value unit, so that you can price the service. I would have to say years ago, that was always daunting, but the last several years with the HSCRC moving to Medicare physician fee schedule RVUs, it's not as bad. Sometimes you can literally find the number you need, multiply it by 10. These instructions are online and you have your RVU.
And with the new technology, you're going to struggle with that.
New technology, yes. So some codes do not have RVUs, but there's always a method to develop an RVU. So try not to be intimidated by that. If you do find yourself intimidated, we help all the time to be that kind of external, like, that looks too high, that looks too low. But anyway, just keep that in mind with the new codes, and then coverage, of course. New technologies are great, but they're even better when like the payer pays for it. So, all right, so we're changing gears unless you have anything else you want to share on Chargemasters. Okay. Yeah. Jen and Christine are going to have a really fun next few weeks, and their teams. Getting ready for January 1. But again, we decided it was not as bad this year.
It really,
So
like everybody gets a holiday this year.
Except for pharmacy.
Yes, pharmacy. They're going to be working.
all right, so the HSCRC and relative value units, we just wanted to update everybody on what's been going on. Some of us have been living through this, but just to make sure everyone's on the same page, last July 1, so July 1, 2022, the clinic conversion, the never-ending conversion.
2 years.
Jen, I believe I will take responsibility. I asked Jen, would she chair that? Because they were looking for a chair. And I said, I have your back. And I had your
You did
back.
have my back.
I had her back. But with the pandemic, so it was already, started out to be overwhelming. And then you throw a pandemic in there. I think it was even longer than 2 years, Jen.
It was a long time.
Anyway, it was a long time, but
Emergency room.
that went live July 1st. And what that means for those of you that don't attend RVU conversion task force meetings for fun, like we do, is every service in the clinic rate center, which is all your scheduled outpatient services that don't fit anywhere else. They're not imaging, they're not lab, but they're scheduled outpatient. They all were revalued, all the services and they moved them to the Medicare physician fee schedule whenever possible. And if that wasn't possible, there's an explanation as to where the number came from in online for the HSCRC. So that was a biggie. That was a big conversion. I know we still are getting questions where, because the conversion happened, and then because of what Sarah, Jen, and Jay were talking about, like things are just getting picked up weird ways. Like we're trying to make an estimate, and we noticed that this happened. So just be aware that did happen July 1st, and most of the dust is settling on it. I know, Jen, you were very happy when that went live, and if anyone had tried to stop and keep Jen on, she would have. You would have gotten a phone call from Jen.
Just as a note, if you happen to go to the HSCRC website, you will not find the updated regulations because they haven't published them.
The manual, do you remember in school when you learned like how a bill like goes through? So I learned about our state government this year, and if there's a reason for that, it has to go through all the approval steps. So I hear that in January or February should be online. In the meantime, if you need the new RVUs and you go on the HSCRC website under memorandums in the month of June 2022, you will see a memo from Bill Hoff and it will have those RVUs. So, but there is a reason why. But some of the areas that are still fuzzy, and they were even fuzzy when we were meeting, but really it was like we had to rip the Band-Aid off. You had to go live. Telemedicine and remote monitoring services still are a little hard to
Wonky.
They fall
Yeah.
in the gray area.
Jen, yesterday you said you get very nervous dropping a charge when the patient isn't physically there because we've been raised with HSCRC rules that the patient must be at the hospital. And if they aren't, they're unregulated. But there are some exceptions, and we're hoping for more clarity. Dennis Phelps of the HSCRC has always said, whenever I bug him, which is pretty frequently, he has said, the HSCRC is attempting to follow CMS. So when in doubt, when you're struggling, what's the HSCRC going to do? Keep your eye on CMS. Now, that's a moving target. So I don't know if that made you feel better or worse, but that's how Maryland is operating. The other area that was very tricky, and we get pulled into a lot of questions, psychiatry, behavioral health. We tried in Maryland to put things in buckets and to say, okay, you're either going to be in the psych daily rate center, or you're going to be in the outpatient clinic, and it's really just become gray. And that's not just a Maryland HSCRC issue. That's across the country. There's quite a bit of language in the final rule from CMS on partial hospitalization and psych patients. So those are two areas that I wouldn't be surprised if maybe we see some subgroups or something like that kind of looking at. But right now, I know people are just trying to do the best they can with the updated Appendix D. Blood, sweat, and tears went into that document. So when you read it, keep that in mind. So that was our past. And where are we moving next? We are moving to rehab. Physical, occupational, and speech therapy and audiology are scheduled to change next July 1st.
And I think it's coming up on 20 years since we've looked at them last.
Well, that's kind of crazy, but because
how
I
is-
remember those meetings. Thanks for sharing that, Jen. Yes, I was 10 years old. It was a field trip to the task force meetings. But anyway, those are converting. We should probably knock on the table again, but because outside of Maryland, hospitals already paid based on the Medicare physician fee schedule for therapy services, maybe this one will be easier. Jen is thrilled that she is not sharing this next one. I didn't. The HSCRC worked with the chair. So.
But it is a clinician, so anybody that's going to participate, you're going to have to probably help pull some materials together. 'Cause
Yes.
The clinicians don't generally do that.
Yes. So data, your financial expertise, if you can come to those meetings, come to the meetings. That's where you stop the train from going too far down the tracks.
It's also just because it's for those that have been around a while and because we have been participating in the task force you have the history of why certain things have gotten to be the way they are. So it's just a good understanding because although we try to really capture the essence of our discussions we've now created a preamble and we've tried to lay out the rationale, but it's really hard to put all of those conversations into words.
This
So
is an area that has a lot of time breakouts.
it does have, so
I'm curious to see if that's going to go away, if we're going to.
I'm glad you brought that up. If you were to pull up the document that we keep talking about, this Appendix D, very exciting document. I highly recommend it. Hundreds of pages. As Jen said, we try to put into words these fabulous discussions that happen. But rehab, when it happened, which I still don't believe you that it was 20 years ago, but if it was 20 years ago, the state made every service time-based, and they used the 8-minute rule. Like the therapy had to be at least 8 minutes to charge for the 15-minute increment, and they made all of them time-based, and that is not how coding is. Certain services are not time-based and other services are. So that would be kind of a big
It makes
change.
difficult.
It could make things much more simplistic.
True.
So there is an opportunity to simplify things. But it's sometimes, I think the clinicians also get used to some of those productivity measures. It's hard breaking out the productivity of why things were there.
But Chargemasters are not supposed to be productivity tools.
Amen.
Thank you.
Just stating.
We're going to repeat that.
Chargemasters are not supposed to be productivity tools.
Mhm. Yep. You will be told no. Yes.
How would one find out about these meetings and how to attend?
The question was asked, how would you find out about these meetings and join in the fun? So Bill Hoff and the team at HSCRC are the ones that will be sending out an invite. And so if you have not been on these task forces before, that means you're not probably on the special mailing list.
And a lot of times I think it goes to CFOs. And so at least in our organization, it goes, some of it goes to the CFOs and then it never leaves their inbox. So it probably, if you're interested, I would reach out to Bill Hoff. Don't tell him I said that, but reach out to him and let him know you'd like to participate. Because as much we've tried to coach our CFOs to make sure they send that out, but I'm not always as special as Lauren to be on those special meetings.
All right.
Before we move on, just one follow-up from the task force, the clinic task force. I know our organizations had some heartburn over the pulmonary rehab codes because there was such a large change, or he's like, yes, you guys are killing me. Such an increase in the RVUs. So it took relatively low values, increased them very much. So there was concern with the pricing. With all things, enough other issues have taken over. So the pulmonary rehab teams have gone quiet, but I wasn't sure if anybody has had anybody bring other issues, if you've had clinicians come to you with concerns.
I think too, a pulmonary rehab is a good example. When you go through a conversion, okay, so if someone's having a service, like a one-time service, and then the price for that service changes next year, not a big deal. But if I'm coming regularly to a hospital and suddenly that price changes, and I'll use the example of it going up because patients usually don't complain if there's a price decrease. Can you imagine trying to explain an RVU conversion to a patient? So that's when I think conversions can be really problematic. Like if a patient's coming for chemotherapy treatments.
I was going to say, I would think the infusion clinic might have had a lot of explaining to do too, because there's a lot of reoccurring patients there.
Yep.
And we did look, I mean, we did try to say, here's what the cost would be now. We had payers that were representative on the task force, so they sort of blessed it as well.
Mm-hmm.
And that seemed to be one that sort of slipped through. And I don't know if anybody just really detailed, but so no major issues from anybody? No.
Just one patient complaint because they had a co-insurance, so it went up significantly.
Okay, so those are the RVU updates that we have for right now. With the time that we have left, first I'm going to ask Kalita, have there been any comments or questions in the chat? Nope. All right, it's Friday. I get it.
People are multitasking as they're listening to us.
Never, Christine, would that happen? Would multitasking be going on? I'm sure. So, just want to spend a little bit of time though talking about. I've personally worked in Christine and Jen's similar positions for the majority of my time in healthcare, but I have been a consultant since 2016. And I don't know if I'm imagining this or it just seems to have become a bit crazy these last few years where you're juggling. I mean, obviously we're in a pandemic. There's going to be situations from the pandemic, but it just seems like even in your role, you're not in clinical roles, but you've had dramatic changes like with your teams, with charge capture, with reimbursement. And I don't know if you each could just take a few minutes to talk about
what you're seeing, how you're responding to it. I mean, there's only so much we can control, which I think we have to remind ourselves working in healthcare, because otherwise you just get so overwhelmed and disheartened, I think is a good word. But Christine, do you want
I
to?
was going to say, I'll let Jen take
Oh,
that.
you
one
want
first.
Jen to? Okay.
All right, I'll start. So yes, I think since the pandemic, I think we're all dealing with more requests, less staff, tightened resources, tightened budgets. I think what Jen McDougall said always, and we talked after that, she's a little bit more patient-centered. Those of us in revenue integrity on the finance side, the patient's a little further away from us. So I think for me, it's always like, it's a good reminder to always remember why we're here. It's always about the patient. So trying to make things as simple as possible where we can kind of brings me back. But so I feel like we've been asked to do more. So the nursing staff, they're short-staffed. They need to take care of the patient. So I think charge reconciliation, which was for our facilities, was owned at the department level. That has kind of fallen away. And nobody's going to really push those nurses because we need the nurses. And we're already, we've all been through the nursing shortage. So who takes it over? Our team has taken over some of that work. Dealing with tightened finances and trying to keep staff engaged and trying to figure out how we pay them correctly. And so I think a big focus is denials, because again, with the GBR model, we've charged these services. So if we are not getting that cash in the door, this is where we make the most kind of
You can't make it up
impact.
elsewhere.
Correct. So I think kind of looking at that, and I know the payer task force has looked at ED denials. And so some of this is all these crazy things where I understand the payers are now really tightening what they're paying. And I feel like there are so many questions. And so, my team sits in revenue integrity. We do fall under the revenue cycle umbrella, but you get your follow-up teams, and that's not necessarily what they understand they know how to do the claims, kind of get things out the door. So I feel like there's a lot more follow-up questions being asked of our teams to help navigate some of these payer issues. And is it payer? Is it workflow? Is it coding? Is it where's the broken process? So I feel like we're doing a lot more of that investigation. Authorizations, which Jen's like, yep, or near like, don't say that word. Trying to follow up on authorizations. Long-term stays because we can't get the patients out. This kind of started in the pandemic when the SNFs weren't taking and we couldn't release patients. And now, if anybody looks through medical records, I'm like, I think people are just tired of I really am trying to be nicer to my kids so they don't just leave me in a hospital. But I think people are left in hospitals because people are just tired and they can't.
You have 4, Jen. One of them's going to pick you up.
I hope.
It's going to be a middle child, because I'm a middle child of 4.
I'm
too.
hoping. Or they're just going to pull the plug, one of the two. But so we definitely are dealing with that. Plus there's all of these, I think just then you look at finance, what data can we pull? How it's all metric based. And again, not having maybe fully resourced, it's what team does it. And for us, it fortunately or unfortunately falls to revenue integrity. I will say we've been in the business so long because I think my role has evolved and I keep learning through that. So to me, that's challenging. Some days it's more challenging. What else?
You had 4 kids. You like a challenge.
I do like a challenge.
Yeah, you did. I mean, you mentioned most of the things that we said, denials, and again, when she was talking about the denials, like with the ED, and you mentioned the payers, there is, and you mentioned, the appendix in the HSCRC, like with the leveling, it's internal guidelines at the hospital with the the background. And so, but now the payers have their own internal guidelines that are developing what they think the different levels, but no one will share what the different levels are. There is not a consistency, but we're still following, none of the hospitals are doing anything wrong because they're following their internal guidelines that they're supposed to, and then can support, but the payers don't agree with yours. So it's a constant battle. Because the payer, and when you question the payer, they're like, well, this is what are you, how are you getting there? They won't provide
They
that
won't share
information
their black
on
box
how they're
edits
getting there, but
to
then how are
level
you supposed to
emergency rooms.
defend if you don't know what criteria they're using? You can't defend what you're doing because you don't know what criteria it is. So I think it's just an ongoing battle. And like what Jen said is, we're getting pulled in more and more to those conversations, those discussions to help defend it, where we weren't before. So.
And I think I had just written some notes too. Then you take your just environmental issues. So I don't know whether other hospitals, we have a big initiative. We're trying to plan for downtime, ransomware type attacks. And I think as we get into that becomes it's made my head swim because there's so many, and we're a large system. So there's a lot of pieces to pull together. We talked about.
Well, I was going to say with that too, with the new remote world, it's a little different because you are dependent on that technology. So if that gets, compromised, how are we functioning?
Yeah. And so, it's like down to where's the phone? Like, I feel like I've gone back in time. Like, where's the phone tree? How do you commute? Who's going where? And where are the forms? And just, it's trying to. Yes.
Yes. Yes. Thank you for bringing that up, Caroline.
Share your experience. Scare people.
You were there too.
Yes, I was there too.
Yes, Christine and I actually experienced a attack where it was shut down, and you know what? We started talking to each other.
Well,
you know how you would shoot an email to your coworker that was like, in the office next to you? You actually got up and talked to him.
I will
And
say her detailed printing out of everything and having everything written came in handy.
I am paranoid by nature. Caroline, how are we doing on time? I feel like, okay. We are going to wrap up, but Jen and Christine, I want to thank you guys for being willing to do this and just kind of share what's going on. I think it's important. You mentioned, battles between payers and providers. Maybe because I've been a little bit external these last 6 years, I'm seeing more collaboration. I'm seeing more collaboration where providers are talking to each other. Payers, we're getting there because at the end of the day, we're all patients. If we have health insurance, we all have to pay premiums that are either going up. I've never seen them come down, but, so I think when you come back to that, it helps. It helps to remind you that we're a different industry from any other industry because we live in our industry, so it's that's what I've been seeing. And I think that's the positive that's come out of the craziness of these last few years. And I think if I could give anyone advice, especially if you're kind of new to healthcare, ask questions. That's what I did. Maybe because I went to school for accounting where you have an auditing class that tells you to trust no one, ask everyone. Maybe that's why I print out hard copies because it was drilled in my head. But I would say question anything that doesn't pass, as Jen referenced, the sniff test. That doesn't make logical sense to me. Now, I will warn you, there are a lot of things in healthcare that are not logical. So it doesn't mean it's wrong, but ask the question and make sure you understand.
And reach out to find your counterparts in other hospitals because as we said, we can read the same reg and we all have a different opinion. Mm-hmm. So I think cast that net wide and pull in groups because I really rely on my counterparts at other facilities to help with understanding or how do you do things? How are you navigating this? Because usually if I'm having an issue, somebody else is having an issue. So
and I know you bashed consultants,
I know,
Jen,
but I
earlier on.
all the time.
But if Kohler is not 100% sure, we have no problems querying. Yes, I'll reach out to Carolyn. So it's okay. We're all people. It's okay that you don't speak government. A lot of the individuals writing these regs have never worked at a hospital a day in their life.
So what made sense to them, they don't understand why it doesn't make sense to someone that works in a hospital. So ask. So, all right, that's our soapbox ending. Thank you, everyone.
All right, so we're going so they can hear me.
Okay, so we're going to transition to our next group. Khalid is doing some technology magic. So we're not going to pull up the presentation quite yet. Nice plug there, Lauren. So we did one thing I didn't mention. So this is a good time to bring this up. Lauren and I are both revenue integrity nerds, as well as many of you in the room. So they do have a resource guide around revenue cycle and revenue integrity, and that is going to be our door prizes for today. And so for those of you that are here in person, as well as those that are online, those are going to be selected after the next presentation. So don't leave and don't log off right away. We are going to make you present to win during that time, because we selected winners from our registration list, and really doing it that way because it's hard for us to see who's all attending currently virtually. So for those of you, if your name does get called that is virtual, just put in the chat, hey, I'm here, and we'll count you. But again, we'll go over these instructions after the next presenter. Are we ready to flip to the screen? Okay. Let me do my stand-up act. Yes. Adrian's like, yes, do.
So if you win a prize, you can email me, and if you need a CPU certificate.
Okay.
We can talk about that.
Yep. So Lauren's email here on the screen, and you guys should see this hopefully online too. If you do win a prize, that will be mailed to you. Lauren will send that, right? That you're emailing it out just virtually. I'm sorry, you're mailing it out.
Yes, we're going to ship it to you.
Going to ship it to you directly. So if you do win, you have her email to contact. If hopefully also in our Menti, we finally got that working. You guys can put your information in to that as well for your certificates, to let us know that you want continuing education certificates to send those out. If you do not receive them, you can harass Lauren for the yes, yeah, all day long. Are we good? Okay. So we aren't going to take a break. We're going to jump right into our next presentation. So I'm going to ask Jennifer Wade to come up from Granite Consulting. She is going to lead us into our next presentation. Before we do that, we do have one last Menti poll. And I love this picture. I found that myself. I thought that was cute. Because how many of us, I don't know about you guys, but I'm less and less on camera these days. So this could be me, literally. Right? So if I'm on calls with you and I'm like, I'm not camera ready, this is why. This is what's happening behind the scenes. So we were laughing amongst ourselves here at the front table. How many days a week do you work remotely? I wanted to put greater than 10. Right? Obviously, there's not 10 days a week. But I work 100% remote. And what we've seen, and that's obviously are going to be our next topic here, is on the remote workforce, is there's a lot of variation, a lot of change even going through as far as where people are working. And obviously these are individual answers. We didn't ask about the team, and I thought about asking where your team's working remotely. But when we talk about revenue cycle, there's definitely a difference between coding, billing, registration. So it gets muddied up. So this is more of a personal answer, for those that are attending. So definitely still seeing a spike of folks that are working remotely. And I can tell you what's interesting is the national perspective on this is going in different regions, just geographically, there's different opinions of working remotely and different changes. That tends to be a cultural piece, and a lot of times driven by executive level, whether and it could be, Lauren was teasing me that I have trust issues. That's with CMS, not with my coworkers. So it really comes down, it's very interesting of how people are moving, because there's very large health systems out there that are saying, I want to be 100, we're forcing everybody to be 100% remote, versus those are like, oh, we're starting to onboard people back in. It's all over the place. So I think it'll be interesting once we get in here and hear some of what we're hearing more locally from our panels. So I was interested. I honestly expected to see more than a 3. So I'm glad to see the 4 to 5. Maybe we'll get some more perspective on where we are with that. So let me pull up. Jen, if you want to come up and we will get you started. And I'll let you do intro for yourself. Are you going to sit up here or just right here? Okay.
If not, I'll just paper it. I'll give you a 10-minute time. Jeff, it'll be when the panel comes up. Okay.
And then there's this one. The thing most used button. Can everybody hear me okay?
Yeah.
Okay, good. So hi and good morning, everyone. I'm Jennifer Wade and I'm with GRC Consulting. I'm the lead medical auditor with the consulting group, and I'll be talking about managing a remote staff. And I forget that this computer is not a touch, which is on our agenda. On the agenda today, we will cover tips on managing a remote staff, best practices for management, and some of the advantages that our companies are now seeing with that new model. Oh, there, you already did your polling. So the pandemic has arguably changed the workforce forever. It has taught us that remote working can be successful. There are primarily 3 distinct types of remote models to consider. As Caroline was saying, there's the fully remote, there's a hybrid, and the flex. It'd be interesting if people could put in the chat if anybody is doing the flex. That'd be interesting to see. But our fully remote teams, they are the ones where everybody is either in a different location. The hybrid, those team members are people that are centralized while others are remote, working at a distance from each other. Most commonly, the hybrid teams exist when the leaders and part of the team are co-located and the rest are not. And the third type of remote is the flex, perhaps the types that's growing the most as well. The flex team are people that are located part or some of the time, but also work remotely. This could include work groups where people do not do a lot of business, travels, but specifically a flex team exists when people work from home 1 or 2 days a week or from the office 1 to 2 days a week. So it'd be interesting to see if you could add to the chat what people are typically seeing in their work models.
Do you want to poll the audience here? So you can see.
Yeah, I mean,
We're
how
not
many?
chatting, only the virtual folks.
Yeah, I mean, how many in the room do 100% remote, or are doing a hybrid, or are doing a couple days at home, or?
100%.
Oh, okay. Yeah, it kind of seems to be that's the more popular choice. Next up, let's talk about some tips to make your day-to-day life easier as you manage your remote team. First up, we have transparency. The best way to encourage transparency is to keep the staff in the loop, share the good and the bad news with them, and welcoming honest feedback from the members of your team. Communication is often as necessary as possible to reduce any chances of miscommunication or misunderstandings, and to make sure everybody understands exactly what types of expectations everybody's expecting from them. So things to remember: to share with staff is clarifying roles, ensuring all required tasks get done without confusion or without any confusions, which can prevent any kind of pitfalls that come from not having them updated. Because surprisingly, a lot of employees sometimes without direction kind of once that task is complete, they don't like inquire for more. So just letting them know things that they need to do is helpful. Discussing concerns, expectations, and goals with the staff. Having weekly one-on-ones, maybe catch-up videos are helpful tools to check in on these items with your staff. Scheduling work hours, holidays, meetings, and calendar. Things like sharing the management's calendars is a helpful tool so everybody can see who's off. I know in one of our offices, the manager did end up sharing theirs so we could see the PTO because we no longer had the in-office calendar to write our days off on. And then even though we transitioned from the office setting to remote, our policy of still just maintaining 2 staff members off per day is something that was still maintained, but still needed to be communicated. Project management tools offer managers a virtual way to see how long an employee spends on each task and how many breaks they take. It allows staff to become more self-aware and accountable for their work management as well. A project management tool that we use is Monday.com. I don't know if anybody else uses any kind of management tool or if everybody's kind of using Excel.
What kind did you say?
Monday.com. And last, encouraging honesty and transparency in work. An open and respectful work environment is key if you strive for honesty among employees and staff. As much as honesty is the best policy, life has taught us that it's not always the case. Not everyone appreciates honesty. That's why it's important to build an environment where everybody feels accepted, heard, and free to communicate openly. And that's one of the biggest things learned from remote working is the communications and ways to kind of simulate what it was like in the office setting. Second, we have practice constant communication. With remote work, some communication is just naturally lost. Being able to tap someone on the shoulder to have a quick chat just isn't an option anymore. It almost kind of feels a little bit invasive when you want to just kind of like quickly, do a Zoom call with somebody because you're like, are they available? Or are they not? So, but it's necessary. It's not necessarily a bad thing that we can't tap our employees on the shoulder anymore. But we do have to do a lot more intentional planning to choose the communications these days. Some of the best practices that we had to help with a staff bonding was we usually had weekly meetings for an hour. And in the first 15 minutes, we allotted the first 15 minutes to break out into sessions. And it was 3 employees each. Because what we found is that when the employees were in a smaller group, they tend to talk a little bit more. So we always encourage non-work related items just to get that personal growth with other employees. One thing we tried to continue that we did in the office setting that we wanted to keep in the remote world as well was like birthdays. We wanted to continue celebrating birthdays. So we do schedule like Teams meetings just so we can kind of sing happy birthday to your fellow employees and just kind of keep that going. And one of the fun things we actually did is during the holidays, we used to decorate our cubes or our offices. So we've actually kind of tried to maintain that. And then we'll do a Teams meeting to see who does the best decorated cube. Third, we have using the right tools to keep a team organized. Giving collaboration and file sharing tools. A sharing tool that we use is a share file by Citrix. It's kind of sort of a cloud that sort of holds all the information, similar to what was used in the office. Video conferencing, audio conferencing, and instant messaging is also a really good tool to help keep staff up to date and checking in on what they're projects and goals are where they're at. I know we use Microsoft Video for the video as well as the chatting. I've also used Zoom and WebEx. Does anybody here use Microsoft Teams primarily? Yeah. For calendar and scheduling tools, yeah, typically we're using Outlook. Does anybody use anything different besides Outlook? I feel like that's like the most popular one out there. And project management and tracking software, again, we use Monday.com. I don't know, Excel is still a really good, useful tool for this as well. Monday.com is more colorful, though. Fourth, encourage better relationships between employees. This one's a little bit interesting for management to be tasked with. They're the ones who are doing a lot of the initiating. One thing that we try to do in our meetings is we try to start off our meetings with just small talk, just trying to get the employees talking to each other. One of the things we'll ask is, do you have any updates? Did anything happen interesting over the weekend? And the other thing we try to do towards the end of the meeting, if it's applicable, is doing any kind of employee recognition. Another thing we do to try to encourage the relationships is just we do weekly meetings on camera so everybody can kind of have that face-to-face visit with everybody. And one thing we tried, interestingly enough, during the pandemic is we tried a live work session, and it was for fun, and it wasn't a lot of time. It was just about 20 minutes or so, but we had everybody have their cameras on, and we had them wear the ugly sweaters. And we just, during December, and it was just kind of fun. We kind of chatted a little bit, but got to see each other while we were kind of working for a minute. I do like how the HFMA is doing the virtual coffee breaks. I really like that, just to kind of see what people are doing outside of work. I think those have been interesting topics. Challenges in managing a remote team and how to solve them. A common communication issue arises usually when the employees are in different time zones. Asking members to work certain periods of the day that will keep everybody connected. We don't experience anybody working outside of our country. I don't know if anybody's working with anybody globally. So we were able to usually find some point in time where we can all get on and connect and have a meeting. I know one of the rules that we did have was you couldn't log on any earlier than 6 a.m. Eastern Standard Time, but that could be something that's created. The second challenge would be collaboration. Ensuring collaboration. Today's tools take advantage of an always connected network with real-time access to files and collaboration suites for distributing teams and hybrid work. The benefits of collaboration tools mean greater efficiency and better productivity. Most tools are designed to take some of the burden off of management. Whether you've been trained for a remote management position or you're learning through trial and fire, here are some best practices to keep in mind. Was anybody doing remote prior to COVID? Yeah. Okay. So it was a little bit of an easier transition.
It was. I'm kind of glad you asked that question because I felt like other people could relate to the challenges, like where your dog doesn't bark unless you have a conference call.
Yeah.
Things like that.
Yeah. Then the lawn company comes.
Yes.
Pretty more difficult getting used to everyone else being home.
Yeah.
Yeah, very good point. Yes, we love our children and we love it when they go to school or college or their jobs or wherever.
Yeah, because I know when I was under MedStud, they had a policy where if you were working remote, you were still kind of required to have childcare. But it didn't count for my husband, who was walking around sometimes in the background. I'm like, oh Lord.
I love that.
Boundaries. Define clear expectations around specific goals, roles, as well as the work performance should be laid out clearly to employees. We don't want to leave any unanswered or any topic unclear for the employees. Some things they may want to be specific about are when everybody needs to be available. One thing we found is everybody was just kind of just logging on when it was convenient for them. So we did have to kind of give some ground rules regarding that. What communication strategies to use? So people really had to transition from using Outlook a lot to just doing it in chat. So it was a little bit more real time. Whether meetings are mandatory or voluntary. How that came into play for us is that we had some cross training that we were doing. And so we broke up some of the employees by the specialties they were in. So 3 specialties would get together, but we did encourage other staff members to join those calls just to learn and hear what those other staff members were saying about their specialties. So those ones were kind of a voluntary meeting. And how project deadlines are laid out. And that is just something we did with training on using like the project management tool like Monday.com, like how to use it and make sure that they understood where and when they needed to put in their pieces to move that project along within that software. Okay, embracing and encouraging diversity. Have you ever advertised a vacancy and had a disappointing collection of applicants and thought to yourself, I wish I could expand my pool of candidates? Well, that day has arrived for us now with remote working. It gives employers the option to hire from across the country and increases the diversity and the talent of the applicant pool, which is a great thing because now you can advocate for the best of the best. Plus, the more diverse your team is, the easier it is for you to access a range of insights and inputs from different people, which is always nice to have different perspectives. Working on your communication skills. Having an open door policy is one of the most classic strategies for promoting communication. When a manager's door is always open, employees can freely ask questions, share their concerns, or ask for advice when needed. This promotes an environment of trust and a sense of transparency between the managers and employees. Maintaining and keeping motivation. Even though we can't see our team in person anymore, a video conference is one of our major assets in our toolkit to kind of maintain that motivation. The videos provide valuable context and it makes the remote work experience feel more human than the phone call or an email. While not every meeting needs to be a video call, create a policy for when a video is expected. It's also critical for the team to have fun and face-to-face conversations like that sort of thing. That was kind of a fun thing. And it was just kind of a relaxed conversation, but just a way to connect because we've had several employees that had been hired during COVID, but I've never seen them in person. Some people have considered hosting a virtual happy hour or encourage your team to play a monthly game. That's something that we've actually kind of done as well during the holiday seasons is play games. We play bingo. That's kind of one of the funner ones. Make sure the space for a more relaxed conversation is available, and that will help keep the team a little bit more connected. Because that's what we all like a little bit more is the fun stuff than always business. Another thing that can keep the team motivated is a little acknowledgement. That can go a long way in motivating employees. Recognizing the efforts of employees can be done in numerous ways, and it doesn't necessarily have to be a huge gesture. Something as small as just saying, thank you or kudos on that project in a team meeting, or highlighting their accomplishments in an office group can go a long way in motivating the remote employees. Making the employees feel like they are trusted can go a long way as well. At some point, the duties have already been assigned to the employees. The best way to show that the employees are trusted is not to micromanage after the tasks are assigned, of course, as applicable.
I was just elbowed with that comment, so.
I
Sure she heard.
know. I wish that away thing in Teams sometimes you could like update it with like in the bathroom, or because you always get.
You do be right back.
Oh, can you? Okay. I went to.
Nobody pays attention to it.
I do, Sarah. No, I didn't even know you did that.
Advantages to remote working. The verdict is out. Remote workers are much happier than the regular office goers. So let's see what the unique perks are that are making this type of worker happier. Some of the advantages to working remote are increased job satisfaction. Remote work can bring employees, increased job satisfaction that remote workers can bring employees is another positive effect. This is because the ability to work from home often provides employees with work-life balance. I definitely don't miss sitting in traffic. And it's also even saved some money because you're not having to spend as much on clothes and everything and gas. So that's always a nice thing. Happy employees are also less likely to leave their jobs, which further reduces staff turnover and associated costs with training new staff. Productivity, improved performance also affects the bottom line of reducing the need for overtime and extra staff, which is great because it sounds like we're all working 7 days a week. Increased recruitment and retention. When remote work is an option, businesses can cast a wider net when recruiting new employees. This gives them a better chance of finding the best possible candidates for the job. By offering remote work, they can level the playing field and attract top talent, because that's just one of the data elements that are out there that the employees are just now preferring that option even over a pay raise. Some additional advantages: absenteeism. Employees are happy and satisfied in their jobs, and they're less likely to take time off for being sick. I admit I will give it a go in the morning, and if I feel like totally bad by the afternoon, I might step out. But I usually do try to give it a go if I'm not feeling so well, and then not be on camera that day. Stress. Working from home can reduce your stress level for a variety of reasons. For example, you no longer have to stress about running late or rushing to get to work on time. Instead, you can take a break during your workday and walk around the block or get a meal to refuel you for the rest of the day. This flexibility can help you prioritize your well-being so you can continue to work effectively and enjoy a balance between work and life. I do appreciate, I think I get back almost 2.5 hours of my day for not traveling. So that's really nice to have that time back. Helps me do my HelloFresh box because that's also saving me a little bit of time, but got to prep it. Green program or environmental friendly benefits from this. Working remotely can promote an eco-friendly lifestyle for a few reasons. By limiting the amount of time you spend driving or taking public transportation to work each day, you can reduce the carbon footprint. Working remotely also helps reduce office-related expenses such as paper, electricity, heating, and air conditioning.
Invite our panelists up and I'll
switch over.
Yeah.
Mentee.
Okay.
All right, guys, so we're going to a second here just to transition because the next piece of this is bringing in some panel participants. So I'm just going to show in the background. I don't think that's going to change too much, but just as a reminder, plus I like that picture. I think it's funny. Laura's laughing at me. So I will let you guys, let me get this microphone over to you, Jen, and then if you don't mind having your panelists do an intro. And then for those of you that are virtual, make sure you stay on after our panel discussion because we're going to do our door prizes.
So I think I might hand it off and let you introduce.
Perfect.
Okay, cool.
My name is Matt Riley. I'm a branch director with Robert Half. As Carolyn mentioned earlier, we own Protivity. We're the largest global staffing firm. I've been doing this for 6 years. Prior to that, I was in public accounting at Grant Thornton and did a small stint at Stanley Black & Decker.
I am Laura Wingard. I work at the University of Maryland Medical System. I've been there for 21 plus years. So I've been there a very, very long time. I work with Jennifer Gardner, so I'm under the revenue integrity team that we recently just transitioned into revenue cycle. And it's a pleasure to be here today.
Hi, I'm Tawanza Hassan. I'm the Executive Center Director at Children's National Hospital. I've been there a little bit over 4 years, but I have worked in for-profit, not-for-profit, and the government, all focused in healthcare. So really excited to be here.
Yeah, thank you guys for being on the panel today. One of the first questions we have is, how often do you meet with your remote staff? Is it by phone or video with the cameras on or off?
I'll take that. And I'll start off. I don't know how we did full-time in office prior to this. I have a 3-month-old and I can't imagine like getting home at 6:30, 7 o'clock and then they need to go to bed at 7. Like I would never see her. Right. So I just am really, I don't know how we did it. Done this 3 years ago. I meet with my team daily. We have a morning kickoff meeting. Then we have a PM like around 3:30, 4 o'clock, depending on what time of year it is when my coworkers have sports or different things with their kids. But we do morning and afternoon. We talk about what we're going to do for the day, what our goals are individually and as a team. And then in the evening, we talk about, hey, how was your day? Where'd you get held up? Where did you struggle? And that gives you time to take away, hey, let me jump on that for you tonight. I can help you out there. And that's what we're doing. That's what we recommend. Those touch points. And we do it virtually in a video. We don't care if it's in the morning, you're in your sweatshirt, or you haven't really gotten like yourself together yet. But we just feel like that connection helps as well. So, yeah.
I like that. It sounds like you do it both times of the day.
So morning and AM and PM.
Yeah.
They call it a huddle, a board meeting, whatever you want to call it. But twice a day, it really helps with the engagement. And then, like for me, from a management perspective, I get to know what my team's doing, right? So if I'm talking to you and you say, hey, I'm going to knock out these 3 tasks, then I can follow up with you around lunch and like, hey, you getting held up at all? I know what you're working on. Is there any way I can help, for the rest of the day so you can get done at a normal time?
Yeah, and then it's like less time in a software, project management software, like kind of reviewing that in the background.
Yep.
You can actually engage. Yeah,
Yep.
I like that. The second question we have is, how can you stay connected with your remote staff?
I'll take that. I have the luxury of overseeing operations, which is boots on the ground, folks who are actually in centers. And then I also have the luxury of working and managing a back office business operations team. And so in a union and non-union environment. So I have to be very fluid and flexible. There are some teams, exactly right, we do morning huddles. So I had to take over a WIC team, right? Some of you may be familiar with that program, but we had to do morning huddles where they operate out of 3 different locations. And we just get a pulse on how's every day going. Did you complete your COVID screening? Is there anything we need for the day? That kind of check-in. Then I have a very high functioning business operations team where really, I've already hired you for the hard skills. And so it's really more about how can I empower and make sure that I'm available to get barriers out of the way. So I kind of have to navigate between actively being engaged and then being able to pull back for the different levels of workforce. So utilizing Teams for us has been the greatest thing. We're able to put calendars in Teams, documents in Teams, record our video sessions in Teams. So that's been really helpful. We've all also gained better relationships where, we're texting. Normally we like to kind of cut the line off because sometimes barriers or boundaries are blurred, and sometimes staff don't want to be texted or communicated after work. And so I'm very flexible in what is your style of communicating with me so that I can then adopt that in reaching out. So I think just looking at each of the employees, thinking about how you can get the best out of them, and then get engaging in that way. So it can be Teams, it could be Outlook, it could be just texting me personally, or sometimes I'm out 3 days a week, but my centers are across, so I'm on site. So I might be in Shepherd Park one day, Shaw Metro another day. I think it's very important for our staff to see that we are present, and that presence means that sometimes they do require me to be there. So I think for me, I've had to be a lot more flexible and fluid, more so than I had to do before the pandemic.
Yeah, I do think on a manager's perspective, that's definitely added to what everybody has to do there. And it's great that you like to text. I always get worried about that because my daughter loves my phone. She has an iPad, but she loves my phone. And I always get worried that she's going to be texting the wrong people.
And I let me just say, someone talked about the kids and how awkward it was in the beginning when we were all forced to be remote, and the pets were across the screens, and the kids were coming in as our unpaid staff. I learned to kind of be graceful and show grace, because I myself would get very, my kid's in the background, and it made me be a little bit more empathetic of that time when someone's little one came in. This happens, so that they would stay relaxed and calm and would be more centered. So a little bit more of a personal thing, but it really enhanced my empathy and grace, and how I try to make others a little bit more comfortable in a time where it's easy for us to get frazzled.
Yeah, I'm glad you shared that, because over the summer, I have an 8 and a 5-year-old, and my 5-year-old girl loves to come in. And I was on a call. I was like, no, you can't come in. I locked the door, and she's crying on the steps. And I put my headphones in thinking that the person on the video call wasn't hearing that, but they heard. And they were like, it's okay. So it made me feel a little bit better that I was like, okay, I'll be out in a minute,
Yeah, I think it's even a challenge today, right? So I think in, early to mid 2020, when everybody was forced to go fully remote, right, and trying to figure things out, I met more of my coworkers and my clients, like their dogs and their kids and their family members, and you got to see them in a less professional setting where they are in their sweatshirts and or they had to go get changed because their kid threw up on something like that, right? And so you learn more about them as a person then. Where now that we've adapted and we're continuing to now focus on this is our workplace now, it's become less and less of that. So you need to find a way to connect with your team and your clients in a different way now, because we're used to it and we've kind of positioned ourselves back into like, oh, here's my office now, and I try to avoid those situations, right? But yeah, my 3 months sits on my lap on a lot of my calls because wife needs some time to herself sometimes. So.
And participants appreciate it.
Yeah.
My baby's turning 16, so I love seeing babies.
Yeah. Well, I'll just give you my phone. My entire phone now is just pictures of her. So.
Mine is the cat.
Yeah, there you
So
go.
I transition.
Yeah.
Our next question: what creative way have you found works to promote employees to speak up during meetings?
I'll take that. I think when it started, it was a struggle for, I have two different teams, but you have to get comfortable with asking questions and then sit in silence. And believe it or not, I found that people eventually don't like sitting in silence. So they will start talking. Something else that we've implemented in our meetings is we always spend the first 10 minutes of our meeting starting with just casual conversation to help them get to know each other. So again, trying to add that personalization into it, I think helps build your team and make them stronger. We have done a lot of, I have a very, I think, creative, fun team. So they come up with some ways where we can do virtual happy hours, or we'll have virtual game days. And we've split up and used the technology that it will spit out questions, and we will battle against each other. So, we've figured out ways where they can start building their confidence, building their relationships with each other. And then when we kind of flip that from a professional side of how can we continue to build their confidence and speaking up when it comes time to supporting their roles, my team came up with a great idea that they were like, you know what, can we spend and designate 15 minutes of our weekly team meeting that we will pick a topic of our choice and we will present it. So I love the fact they've come up with some very creative ideas. Some of them being, again, something that is related to the industry or something that was non-related, but it made everyone fun. So that was kind of, I think, in the start, that was our approach, but I have a very talkative group now. And I think had we not taken those steps, they probably wouldn't participate and be as engaged. But they really run the show now. They facilitate our team meetings. They coordinate everything, which is, I think, absolutely great.
Yeah, for personal development, if they want to expand, I think that's
and
great.
It's less responsibility on you as a leader, that they are stepping up and wanting to do the work.
Laura, is your team age-wise mostly young, mixture?
It's a mix. So I have some very seasoned, experienced analysts. And then I have some that just fresh out of college, we are grooming them to be analysts.
So I think that's even more important, that kind of team building when you have the different perspectives. Taking a course on generation gaps was very eye-opening to me. I'm a Gen X, and I just always saw it as a Gen X.
Yes.
Had no idea there was other perspectives.
Yeah, even just with computer and technology, just being an 80s baby and things always changing all the time. Adapting to software wasn't something that was uncommon for me or didn't make me feel uncomfortable. But as we've changed softwares and EHRs, the older staff members struggle with those changes sometimes. So just slowing down and just trying to. But
Are you the person that we're like, you're double muted, Lauren? We can't hear you. If you're talking, we can't hear you.
Never.
Or you dialed in using your computer and your phone, and now we all have to sit here and suffer with the terrible echo.
It happened yesterday, however, and my boss, who is actually significantly older than me, told me what to do about it.
But there's always something to learn. You guys were probably on the AMA symposium. And were you there for the dance session? But they had this virtual dog that came in and started dancing. And I just thought that was the funniest thing. It's very silly. But with you guys meeting twice a day, I think this might be a great question for you. What does your team building look like? Because it sounds like you meet a lot.
We do, right? And I think, we obviously make the small talk in the beginning or the end of meetings and things like that, but we have to find ways to get to know each other. And that's the way I kind of look at it, is whether it's a client or a colleague, I know you by title, right? If you're, a rev cycle manager, you're a CFO, you're a controller, whatever it is, I know what you do, right? Ballpark, I want to know who you are as a person, what motivates you, what do you like, what does your family like, right? Do you go to Penn State or, West Virginia has a big game against Penn State. We were talking about this earlier, and coming up the next fall. But I need to get to know you, right? And so we do things like Family Friday. So Friday morning, you have to send a picture of your family to the group chat, like with our team. So you get to see whether it's your dog, your cat, right? Your kids, whatever. So we do that, just updated pictures so we get to know each other that way. We've done the virtual happy hours, but the way we've done it, because it's really hard in a Zoom or Teams meeting setting, if there's going to be 20 of us, right? Somebody's going to dominate the conversation. It's typically me. I'm a very vocal person, right? So I'm typically talking the whole time. But it's really hard to just take one-on-one conversations that you get if you went to, stained glass pub around the corner, right? And so what we would do is have somebody lead a drink mixing class, right? So like when I'm a big whiskey guy, so I hosted, I made old fashioned. So the week before, I'd send out all the ingredients, everything that you should buy, right? My recommended whiskeys that I like. And then I would teach everybody live in a class how to do it. And so we've done that. We also encourage phone calls. So on Thursdays, if you have a question for a coworker, you call them rather than message them, because that allows time for that water cooler, small talk, complaining, right? Like complain about me, your boss, whatever it is. Like you need your colleagues to be able to talk. Jay?
So I'm kind of curious with the virtual happy hour.
Yeah.
How do you navigate, whether you know or not, someone who doesn't drink,
Yeah.
or someone who's in recovery?
Sure.
That could be a very exclusive.
Sure. It's not required, right? We typically do it with like multiple teams. And it's not a required thing. We do it at 4:30, 5 o'clock. If you can't attend, you get on the 10. We don't get 100% attendance on it. It's not saying, hey, you have to come to this. So that's how we navigate around that. It's not trying to single anybody out. It's not a team of 3 or 4, right? This is kind of combined in a couple of different groups across the organization.
Ooh, it sounds like the topics might change as well.
Yeah. And it's really important that you find ways to engage, because we talk about, you mentioned that working remotely increases retention. But one of the things is that working remotely, 60% of people that work remotely now feel like individuals and not part of an organization. So when somebody calls, I forget who said it earlier, but when I can get paid $1 extra to go to another health system, I'm not really part of OMS, or I'm not really part of Hopkins. Like, I don't really feel that way because I just work remotely and I don't know these people. So giving notice to a boss that you don't feel friendly with, or you're not engaged with, or you don't get to know, is really easy to say, hey, I'm done in 2 weeks. But somebody that's been working for a while and they leave you to go to another organization, it's harder to let that person go. And you might write a long LinkedIn post to say goodbye to them. But yeah, so that's important, right? And so we need to find ways to build that collaboration within the team. Yeah.
So I have a question. So this conversation is foreign to me because all my staff is on site
Right.
all the time.
Right.
And I like to work from home once a week if I can.
Yeah.
It's nice if I'm sick, I can
Mhm.
over the work, but I guess what I struggle with are I don't like the term hybrid, right?
Right.
I mean, it's very tough for me because it confuses the employee.
It
They
does.
don't understand what hybrid means.
Yes.
And so how do, and this kind of questions for everyone up there, are your roles just, outlined? It's a remote position. I'm applying for a role within your group.
Uh-huh.
It's a remote position. We are in the process of moving as many, because hospitals need clinical space.
Yep.
So where we can move a group out that makes sense, like a scheduler,
Mhm.
an insurance verification group type thing. If we can move them home, we're trying to move them home. And then we have people that are like, but I like to come to work every day.
Right.
I don't want to go home. I don't want to be remote.
Right.
But we're advertising these roles as remote.
Yeah.
And we're really, saying, okay, you're now remote.
Yeah.
We do have people, and we actually have made special accommodations for a couple of folks because they don't have the means to work.
Sure.
They don't have access to Wi-Fi. Maybe
Yep.
they live in a remote area. Maybe just their financial situation doesn't allow them to have that access.
Yep.
So I guess so it's like a 11-part question. I just
Yeah.
Do you advertise your roles as remote?
Yeah.
One. 2, when you use the term hybrid, really, what does that mean?
Yeah.
I guess in your definition. And then, so take those
Yeah.
first, because I do.
So the question was, when you're posting a role in today's environment, Do you post it as a remote job or as a hybrid job or nothing at all? And then secondly, what does hybrid mean? So I found I'll answer the second part of the question first because I think it's easier. Hybrid to me is kind of a set schedule. I found success in like my team. We go in Wednesday. We've been going Wednesdays every single Wednesday. That's when everybody knows that we're going in. We are flexible in the sense that if you got sick, obviously, please don't come in. Right? You have a stuffy nose, please don't come in. If that day your kid has a chorus concert at 2 and it just makes some sense for you to work from home that day, right? We get it. There's that flexibility of it, but we have that set schedule. So the expectation is if you're going to the office, Wednesday is that day. So yeah, the second piece of the listing it, I would rather list it as nothing and have that conversation with the individual, right? I wouldn't list it as remote. I wouldn't list it. So that way you're going to get applicants, because the hardest part right now is getting people to apply to positions. And even at Robert Half, a staffing firm, like we used to be able to post a rec on a Friday afternoon and show up on Monday morning and have like 13 to 20 applications. Now we're getting 1 to 2. Now it's our job. We get paid to go find people, but still, like we used to be able to post things and get applies to that. So I would keep it as open as possible and have those conversations with the individuals. The problem is that we're finding is that everybody's different, right? Like, some people are saying like, I will not drive. I don't care if it's 10 minutes from my house. I will not go to the office. I'm working from home. This is what I'm doing now. And they could have the background you want, the skill set that you want could be awesome and not really worry about money, but they want to be from home. There's other folks that want to be in the office. I need to be in the office. I want to collaborate. And so how do you balance that with Matt, who wants to work from home, and Laura, who wants to be in the office, and then you're making special considerations for Tawana, right? So that's the challenge. And
and really the space part becomes a challenge.
Right.
Because, you have to build touchdown spaces for these remote employees and then have policies and procedures if you're having equipment issues. Or have you, and I know we're all just sort of thinking about where they're going, and I'm on board for it. It's just, we almost need like a remote workforce leader, who's going to coordinate all those efforts.
Yeah, and Robert Half actually has a remote workforce team that sits out of corporate and has done, so they've taken small teams, done some case studies and saying, okay, this is the way we're going to do it. How did this work? And go from there. I don't know if anybody else wants to add to this.
Yeah, I mean, Jen, for my remote positions, I do post them as remote and they are 100% remote. And I have found that prior to adding that into the job description online, I wasn't getting that many candidates. The moment that we added remote into the job description posting, we were immediately getting the candidates that I would have expected to get for those roles and positions. Now, I don't post the word hybrid for my analysts that I need on site. That, again, to his point, that's part of the conversation and setting expectations to see if that's something that they're even willing to consider. Because I have had people that say, you know what, I'm not even interested in coming in if it's 1 day a week. I was looking for something that was 100%, remote. And unfortunately, I think that there are jobs that it fits very well to be remote. And there are positions where I think it's important for them to have some type of interaction and activity.
So I will answer completely on the other side. I don't post anything as remote, although I offer the flexibility. And partly it's because I'm in an academic institution, physician-led, and many of our seniors have a different philosophy. And so I am oftentimes piloting through action to show that giving that flexibility is leading to increased productivity, increased well-being for the staff. So from my perspective, I can't really label it as remote. I do have to go back and have the individual conversation, but I'm also managing up to show at the same time there is advantages to it. And then my mind goes to where I also work and live, as I also have to show to my CFO, right? Because there's some costs, right? We've spent millions of dollars in multi-year leases, and all of a sudden I want to tell him,
yep. We don't need that space.
So
it's also a part of a dynamic of managing up to my leadership, but at the same time having a push and pull to my CFO to say, we can rethink how we're utilizing some of our infrastructure and real estate to those touchdown hoteling spaces. So don't advertise as remote, have the conversations as Matt does, but then also it is likely limiting the candidates that I am actually receiving because I can't publicly say it's remote.
Are any of your union staff home? Yeah. That's what I thought.
Did I whisper that?
They're not listening.
Blink twice.
Well, you guys, I really want to thank you guys for being on the panel today and sharing some of your insights here and the ways that you guys are handling remote work staff. I found it to be really interesting and learned some new things.
Thanks for having us.
Yes, thanks.
Do you want the names, Karen?
Yes, I can do my best. Bob Barker.
Does anybody even know who Bob Barker is in the room?
Yes.
Okay. He's a little creepy, yeah. You want to do it? Okay. Oh. Yeah, so we'll have Lauren announce our door prizes. So yell here, jump up and down. And if not here, just say here in the chat and we'll go from there. You have to be present to win. So there'll be a short, brief pause before we move on to somebody else, right?
Yes. Yes. In case they're double muted, as I was called out to be. Okay. Our first winner can walk right back, or no, she doesn't have to walk right. She can just raise her hand. Laura Wingard. Congratulations. You will be receiving your Kohler book shipped to wherever you want it shipped. All right. Our second winner is hopefully virtual. Brooke from GBMC. Brooke, are you on? I feel like we're building suspense. Brooke from GBMC. Her last name is Wydek, if I'm pronouncing it correctly.
So while she's doing that, we're sharing something real quick.
So for those of you that still have anxiety about your kids going, hey, Mom, are you on the phone while you're doing a board meeting? Yeah. So there's this wonderful thing. It's under $30. It's on Amazon. It's an orb light, and it has a remote. And I sit it down by my office, and I can change the color. Red is do not enter. Or yell from outside. Exactly. Yellow is text with caution. Green, they never see, but it's I'm available. So it's a wonderful, wonderful thing. Yeah, just a little bit of tidbits. Yes, exactly. Yeah. It works for husbands too, not just the kids.
For more parenting advice, you can email Caroline. Brooke is, oh, all right, bummer. All right, that's okay because we have 4 names if we need to use them, but we're not going to because Jody Reedy, you want a prize. It was super scientific how we selected. I asked random people to give me a number between 1 and 78. And the list that was provided by Holly, our wonderful HFMA support, I numbered all the names. So for future reference, really cool system there. Worked out great. No, not statistically valid at all. Nope. All right. I think those are our prizes. Is it food time? Huh? I can do one more. Yeah, sure. All right. Let's try for one more. Nicole Monica. Congratulations. Nice.
All right, so for those of you that are still logged in virtually, that concludes our program, I believe. I don't think, or was there nice hold music or anything? I don't think we have anything there. They're going to miss the karaoke. They can just hang up. Okay. All right. So for those of you in person, we have sponsored lunches. So there are box lunches. We do not have, unless you want me to do karaoke, we don't have any presentation or anything during that. What we like to do and what we've done with these sessions in the past is to open it up for networking. So obviously being able to talk about what we've talked about today, just get to know one another and just, be able to share. So we have this room, I believe, until 1:30 for lunch. So please take a lunch and get to know a friend. All right. Thanks, guys.
Are we on?